Hello students, good afternoon. This is Dr. Khushbu Mahajan and today we will be revising dermatology before your INI-CET exam. So this is LLR or last resort revision. However, it is not exactly last resort. We'll be always be there to help you and I'm sure you would be revising your subject again and again. But the purpose of this session is to walk you quickly through very, very important topics and questions which have been asked in INI-CET in the exams in the past and which are expected to be asked. This would be more of an image-based revision where I'll be showing you images and I'll be talking about various questions which have been asked. I would want you all to be very active during this session because if you give me answers, it helps me to stay active and we can discuss the common topics, and meanwhile you can ask me questions if you have any doubts. I would request that ask questions related to the similar topic when we are discussing that. In the end, if there is anything else that you want to ask, we can cover that so that the other students do not get confused. And it's always lovely to be live with you guys and to interact with you. So let's start. Before we begin, we all know that there is a champions exam, which is the biggest mock exam for an INI-CET, and this is from 17th to 21st April. So kindly register for same. So moving on quickly without wasting much time. So a topic which is very, very frequently asked. So now moving on to the first very, very important topic in dermatology, which talks about bullous lesions. So the common questions which are asked, like they'll give you an image like this and they will tell you that a 40-year-old female presented with bullous lesions on the body. And now the important clues that may be given to you are the patient has oral erosions, the bulla are flaccid and are present on the trunk and other areas. So when you look at this image, when you look at oral erosions and flaccid lesions, all of you know that we are dealing with pemphigus vulgaris. But sometimes in the similar spectrum, they may give you an image like this, where they may tell you that there is a 40-year-old male who is presented with crusted erosions, which are present predominantly in the seborrheic distribution. So crusted erosions present in seborrheic distribution. So what would be this? So absolutely this is pemphigus foliaceus. So see, both are pemphigus, but the picture is different. In pemphigus foliaceus, if they give you an image, you do not see a bulla. Don't get confused. You hardly see a bulla here because the bulla ruptures very soon. So patient would typically present with crusted erosions in seborrheic distribution, and so there is usually no bulla and usually no mucosal lesions. So patient has no mucosal lesions and no bulla, whereas in vulgaris there is flaccid bullae and oral or other mucosal involvement is usually seen. Okay, now both of them being intraepidermal disorder would present with similar histopath sometimes or a similar DIF at least. Now what is the difference in histopath in both the conditions? So in PF, the bulla is subcorneal, whereas in pemphigus vulgaris, the bulla is suprabasal. So quickly tell me, this histopath image that I have put is of what? PV or PF? This histopath image is of PV or PF? Absolutely right. So here you see this is my basal layer. So quickly revising the layers of the epidermis also. We know this is stratum corneum, stratum granulosum, stratum spinosum, and this is my basal layer. So I see a split which is present above the basal layer. So a suprabasal split along with, yes, lot of you are correct. We see row of tombstone appearance. My basal layers are separated and are appearing as row of tombstone. So row of tombstone appearance, suprabasal split is seen in pemphigus vulgaris. Another very, very important pointer. What is the classical DIF appearance? What is the classical DIF appearance in both PV and PF? Very good. So what is the classical DIF appearance that I see? What is it called? Yes, absolutely right. It is the fishnet appearance which is seen in DIF, which is the gold standard test for diagnosing my immunobullous disorder. So if I have a question, gold standard test for diagnosing immunobullous disorder, it is not histopathology, it is not Zhang smear, it is direct immunofluorescence, which is the gold standard test, right? So you should be clear about all these facts. So quickly revising the differences between vulgaris and foliaceous. Foliaceous is F. F is first. So which desmoglein is involved? Desmoglein 1 or desmoglein first here. Whereas in pemphigus vulgaris, we have desmoglein 3 and desmoglein 1. Both are involved, right? So, but if you have to mark 1, you will mark desmoglein 3. So, please remember F for first. So, desmoglein 1 in PF. Then the separation in foliaceous is subcorneal or at the level of granulosum, whereas in separation in PV is suprabasal or at the level of stratum spinosum. Bullae are more superficial, so rupture easily in foliaceous. They are deep and so can persist for 2 to 3 days. Then mucosal involvement is not seen in PF because desmoglein 1 is not present in my mucosa. So, we do not see mucosal involvement. It is only seen in PV. The site seborrheic areas are more commonly involved in PV. So, please remember these important points because they are frequently asked. Now, to confuse us further, we can have an image like this. You may or may not be given this DIF. Okay, so you would typically get a 60 to 80-year-old female or male, usually elderly population, who presents with tense blisters. So there can be 2-3 pointers in the history: elderly, tense blisters, and the third very important feature that may be given is preceded by itchy urticarial lesions. Preceded by itchy urticarial lesions. Any of these 3 present in the history, the diagnosis becomes absolutely right, bullous pemphigoid, which is a type of subepidermal immunobullous disorder. Okay, so PV and PF were intraepidermal disorder. In subepidermal disorder, the most common one which is asked is bullous pemphigoid. Important pointers. See, we will not have time to discuss each and every topic. So, the purpose of this is I will just give you important pointers which you should look into the exam, which will help you mark the exam. Okay. If you think I'm going fast or anything, you can tell me. But the aim of this session is to cover most of the important topics, right? So, bullous pemphigoid is a subepidermal disorder, tense blisters, elderly, itchy urticarial lesions. Then on DIF, you all already pointed out, there is a linear fluorescence that you see along the basement membrane zone. Linear fluorescence seen along the basement membrane zone is again a classical feature. If you do a histopathology, here you will see a subepidermal blister. Whole of the epidermis will be above, dermis will be below, and there will be an empty space between epidermis and dermis. But the very classical thing is doing a DIF where you see linear fluorescence. Clear? Then there are other signs which help us differentiate between pemphigus and pemphigoid. We can remember it with the help of a mnemonic, MINAR. Mucosal involvement is more commonly seen in pemphigus. Intraepidermal bullae are seen in pemphigus. N for Nikolsky's sign is again positive in pemphigus. Acanthocytes or acantholytic cells are seen in pemphigus, and row of tombstone is also seen in pemphigus. So remember this mnemonic MINAR. MINAR is present in pemphigus and absent in pemphigoid. So these are all the important features which may be there in the question and can help you differentiate between pemphigus and pemphigoid group of disorder. Bulla spread sign may be present in both. In pemphigus, the bulla spread sign is angular, and in pemphigoid it is rounded, right? Perfect. So, Clear? So this is how you differentiate between pemphigus and pemphigoid. Quickly, in treatment, my treatment of choice is, okay, so when I write the treatment of choice, till then I want you to tell me which biological is used for this group of disorder. So treatment is steroids, either oral steroids or pulse steroids, along with immunosuppressants. And immunosuppressants which are used are azathioprine, cyclophosphamide and MMF. However, they frequently asked you about the name of a biological which is used in this group of disorder. Absolutely right. The biological which has been used is rituximab. Okay, so you should know this name with this group of disorder. Okay, moving on. In the same group of disorder, you can get something like this. A child or an adult presents with itchy lesions, itchy excoriated lesions on extensor surfaces of the body. Despite use of repeated creams, treatment of scabies, the patient is not improving. What is your differential diagnosis here, and what is the one thing that should be avoided? Very good. So yes, you're right. This is dermatitis herpetiformis. Dermatitis herpetiformis also comes under the group of subepidermal disorder. However, we see no bulla here. There is no bulla, so again don't get confused. What is the antigen which is seen in dermatitis herpetiformis? Quickly. So you all know everything. So what is the antigen? Quickly. I am talking about antigen, not the antibody. A lot of you are writing IgA. Yes, it is Dr. Sushila, I guess. You're right. It is tissue transglutaminase is the antigen here. Tissue transglutaminase is the antigen here. And what you see in DIF is the dermal papillary tip fluorescence. Dermal papillary tip fluorescence is seen. Okay, so dermal papillary tip fluorescence is seen, tissue transglutaminase, extensors, itchy excoriated lesion. What is the treatment of choice? A lot of you gave me that. So treatment is Dapsone, and very, very important thing here, Dapsone and avoid gluten. So these are all the important questions which are asked for dermatitis herpetiformis. So no bulla formation, UCH excoriated papule, dermal papillary tip fluorescence. Treatment is Dapsone and avoid gluten. How do you avoid gluten? By avoiding BRO, which is barley, rice, oat and wheat. Barley, rice, oat and wheat is to be avoided. What can be taken? Maize and rice. MR. MR can be taken and BRO needs to be avoided. Clear? So all are these are questions which are asked in this group of disorder. Okay, another very, very important thing that is asked is they tell you to tell the based on the level of involvement, you have to mark the different immunobullous disorder from top to bottom. So for this, you need to know the antigens. We already discussed PF is desmoglein 1. PV is desmoglein 3. So first would always be PF and then PV. In subepidermal disorder, bullous pemphigoid is BP 180 and 230. BP 180 is BP antigen 2. So 1 is 2. Okay, students, I hope I'm back on your screens. Am I visible? Am I audible? Can you please put it on the chat box? No? Please tell me if I'm audible or visible. Give me some thumbs up. Okay, I guess some of you, yes. So most of you are seeing me and are able to hear me. So let's begin quickly. Right. So I think we lost connection over here. So I was talking about these immunobullous disorders and their antigens. which are commonly asked, and more commonly they ask you you have to mark them in order from top to bottom. So we already discussed PF is on the top, pemphigus foliaceus vulgaris, and then we come to subepidermal disorder. Here BP or bullous pemphigoid has two antigens, BP 180 and BP 230. 180 is BP antigen 2, whereas 230 is BP antigen 1. Pemphigoid gestationis is nothing but bullous pemphigoid which happens in pregnancy, the antigen being BP 180, BP 230, and commonly complement is also involved here, C3. Right. Next is linear IgA bullous disorder, or here the antigen is called as LAD1. Lower down we have EBA and bullous SLE. Both of them have antigen as collagen 7. DH we already discussed, epidermal transglutaminase. Now sometimes it is difficult for us in exam to remember the exact level. So you can remember this mnemonic: first we pray, then can eat. So first is is pemphigus foliaceus, for V pemphigus vulgaris, pray pemphigoid, then can eat. So C is cicatricial or mucous membrane pemphigoid, and last is eat, so EBA or bullous SLE. Both EBA and bullous SLE are at the same level because their antigen is collagen 7. So remember this mnemonic: first we pray, then can eat. So by this you can mark the levels of various immunobullous disorders. Okay, clear? Now when we are talking about erosions, crusting, so this is also something which you may get. Here you get lot of crusting, peeling of the skin, and typically they will give you history that patient took some drug and developed extensive peeling of the skin with mucosal involvement. So what will be the diagnosis here? Sorry Tane, I don't think so we should go from the first topic. I guess most of you were there when we started with that. We will go revise that if time permits. Okay. Yes, so SJS and 10 is something that you should be aware of. Why am I discussing here? Is Nikolsky positive in SJS 10? If yes, what kind of Nikolsky? Quickly give me that answer. Then another thing that you should know about SJS 10, when do we call it SJS? When there is less than 10% of body surface area involvement, and when there is more than 30% body surface area involvement, I call it 10. In between 10 to 30%, it is called as SJS 10 overlap. Okay, what is the score which is done to predict the mortality in SJS 10? Very good. So the test which is positive here is called as pseudo-Nikolsky. What is pseudo-Nikolsky? We all know Nikolsky test is positive in intraepidermal disorder where you put a shearing force, and since the epidermal layers are already departed, so the skin peels off. Here it is not because of antigen antibody deposition, it is because of drug induced keratinocyte apoptosis and acantholysis which leads to shearing away of the skin. So here also shearing of skin happens, but it is not because of an autoimmune process. So here we call it as pseudo-Nikolsky positive. My next question was, what is the score which is used to predict mortality in such patients? So absolutely right, it is because of necrosis of keratinocytes and keratinocyte apoptosis that here Nikolsky test positive. Okay, so in pemphigus group of disorder you have a positive Nikolsky, in SJS 10 you have pseudo-Nikolsky. Quickly tell me the score to predict the mortality. Yes, absolutely right, Dr. Vara. It is score 10. So score 10 is used to predict the mortality in SJS 10 patients. And drugs are the most important cause of SJS 10. So this is mostly what is asked in this. The next, moving on to the next topic now. Right. So very commonly you would be given one of these lines in dermatology and you have to identify these lines. So can you tell me which is the line which is lighter in color or on the left hand side of the screen? Yes, so very good. So this is Blaschko's lines, and this is the other one is called as, what is the other one called? So Blaschko's lines, very easy to identify, they are curved. Look at these lines. So these are all curved. Strict midline demarcation. So there will be a strict midline demarcation and the lines would be curvy, whereas the other lines which are called as Langer's lines, very good, which are called as Langer's lines are more V-shaped or straight. They are more V-shaped or straight. So you do not get confused. These are usually the two lines which are given. Curved, Blaschko's, Langer's are more straight and V-shaped. What are the differences between the two? Blaschko's lines are actually lines of embryonic development, and so they are constant and there is a strict midline demarcation. Whereas with Langer's line, they follow orientation of collagen and muscle bundles. Now, since the collagen and muscle bundle will vary with time, they are not constant, and they are very important because they help us in giving surgical incisions. So, if surgical incision is given parallel to Langer's line, when you suture it, it heals better. Okay, so they are also called as relaxed skin tension lines. Relaxed skin tension lines. Clear? Good. Moving on to the next topic. You are given a child usually who presents with loss of hair in a particular patch. There is a patchy alopecia that you see. Now quickly, before I move on to patchy alopecia, we broadly divide into two, non-cicatricial and cicatricial. Lot of time they will just give you which of these is not a cicatricial or which is not a non-cicatricial alopecia. So non-cicatricial is also called as non-scarring and cicatricial is also called as scarring alopecia. Okay. Now just remember the important causes of each of them. For cicatricial or scarring alopecia, the important causes that you should remember is LP, DLE and pseudopelade of Brock. LP, DLE and pseudopelade of Brock, LDP. For non-cicatricial alopecia, and here again you divide it into, it can be patchy, it can be diffuse or it can be patterned. Okay, so non-cicatricial alopecia can be patchy, diffused and patterned. If it is patterned, we are talking about androgenetic alopecia. If it is diffuse, we are talking about various effluviums. Okay, this is a quick revision of what are the various causes of alopecia. Now, coming to this question, a child presents with patchy alopecia. So, what are your DDs and how do you differentiate between them when you get patchy alopecia? So, in the right side image, the question would typically be a patient presents with patchy alopecia with some grey colored scales on top. There may or may not be itching which is present. So what is the diagnosis for the right side, for the left side of the image? Absolutely right. So this is tinea capitis. And which form of tinea capitis? Grey patch. So now why I have put both the images together? Because these are the differentials which are given in the question. Whenever you have a patchy alopecia in the child, look for presence of scales. If there are presence of scales, you mark it as tinea capitis and specially grey patch. However, if you see something like this, very, very smooth, non-scaly, asymptomatic in question, what will be my diagnosis? It will be alopecia areata. Right? So, please remember these points. If it is smooth, non-scaly, you see a normal skin and just a patchy alopecia which is asymptomatic, this will be alopecia areata. However, if there is scales, you would mark it as tinea capitis. And which particular type? Grey patch type of tinea capitis. The next important question would be, how do you differentiate? What would be the test that you do for this and what would be the test that you do for this? So for this, you would definitely do a KOH or a Woods lamp fluorescence. Either of this given you can mark. However, the better test would be a KOH. When we have grey patch, it is a type of ectothrix. It is a type of ectothrix, the most common organism being Mycosporum canis. And this is the type of tinea capitis which is responsible for outbreaks in school, because the scales are on the surface, so can transfer to other students, right? So these are the important things here. It is ectotrichs. Wood's lamp fluorescence would be present because the scales are on the surface. You would see a positive Wood's lamp fluorescence. The investigation of choice would be KOH, where you see an ectotrichs infestation and a Wood's lamp fluorescence which can be positive. What is the treatment of choice here? What will be the treatment of choice here in tinea capitis? Very good. So you all are very well aware. So we can quickly cover these topics and all the important questions. So what is the treatment of choice here? So yes, treatment of choice here is griseofulvin. We always give oral treatment for tinea capitis. Even though it is a child, we do not treat them with topicals because it is a deeper infestation. And this is the only indication in tinea where griseofulvin is the drug of choice. Now coming to quickly this form of alopecia which appears smooth, asymptomatic, alopecia areata. The test is here. Exclamation mark here seen at the periphery of the patch. Exclamation mark here seen at the periphery of the patch is the test is one test that you would do here, or they can ask what can you see as a finding. Another important thing that they may give you in alopecia areata is persistence of white hair, because alopecia areata does not affect white hair. So on the patch you can see white hair which is present. Okay. Yes, if you do a histopathology, you see swarm of bees appearance, which is nothing but T lymphocytes which are infiltrating the hair roots. Swarm of bees appearance on histopathology. What will be my treatment here? Quickly, in alopecia areata, what will be my treatment? Good, you guys know everything. So yes, when you do a nail examination, you might see regular pits on the nail plate. Regular pits on the nail plate may be seen in alopecia areata. The treatment here would be intralesional steroids. Intralesional steroids would be my treatment of choice for this kind of alopecia. Okay, now quickly, in patchy alopecia, we said tinea capitis is one reason. Then we have alopecia areata. What are the other causes of patchy alopecia? So I'll tell you quickly, it is moth-eaten alopecia as can be seen with syphilis, and also pseudopelade can present with patchy alopecia. I'll quickly discuss that subsequently. So this is ectotrichs infection and exclamation mark here which I already discussed. So this is another thing that can be given to you in patchy alopecia, where you would see there is loss of hair which is a kind of diffuse but is present only on one side of the head, and in the patch you see hair which are there of various lengths. So you see no scaling, you do not see a smooth patch, but you see hair of various length. Yes, this is trichotillomania. So if you now get a question on alopecia, you know how to differentiate between different patchy alopecia. So here you have very, very importantly hair of various lengths. And then what else can be given? A history of psychiatric disorder. History of psychiatric disturbance or disorder may be given to you in the exam. Hair loss is limited to the dominant side. Like if the patient is left-handed, you'd see it on the left hand. If right-handed, you'll see it more on the right hand. So one side of the scalp is more frequently affected. What is the sign that is seen with trichotillomania? Yes, you're right. You can see perifollicular hemorrhages here. There can be associated trichobezoar. You need a psychiatric reference. Very good. And what sign? There is a sign which is associated with trichotillomania. Quickly give me that. Friar Tuck's sign. Absolutely right. So Friar Tuck's sign is seen. He was a character in Robin Hood movies who had this particular type of hair which was depicted. So Friar Tuck's sign is seen. Okay, so patchy alopecia. And the last is moth-eaten alopecia, which is seen in syphilis. Okay, so these are the different kinds of patchy alopecia that may be given to you. If it is moth-eaten alopecia that they want to ask, they will definitely give you other signs of syphilis which may be present or VDRL positive, because a syphilis patient will never present with just moth-eaten alopecia. Remember that. Right? Now quickly, since we were talking about tinea capitis, I'll quickly discuss the other variants which are asked. So here, this is, you can see lot of black dots here. So this is a black dot type of tinea capitis. It is an endothrix infection. That is why, what are these black dots? They are nothing but swollen hair shafts. Trichophyton tonsurans is the causative organism. Now here it is endothrix, so fungus is inside. So if you do a Wood's lamp, it will be negative. Wood's lamp would be negative. And this is also a non-cicatricial kind of tinea capitis. Both black dot and grey patch are non-scarring, whereas these two other variants are scarring kind of tinea capitis or inflammatory type of tinea capitis. Clear? Very good. So this is right. So what is this? What is this image of? The typical history here that you would get is boggy swelling. Boggy swelling with hair loss, with pustules, and mostly KOH negative. This is KOH negative. Wood's lamp negative. Yes. Chirion is the answer here. So, presence of boggy swelling on the scalp. Anything given. Boggy swelling is typically used for chirion. So, please mark chirion here. Why is KOH negative? Because of so much of inflammation, the fungus is actually killed. The manifestations are because of inflammation. One of you pointed out there is history of pet dog. Why? Because it is caused by the species of fungus which affect the animals or zoophilic species. The common fungus which is causing it is Trichophyton. Give me the answer. Yes, verrucosum and mentagrophytes. Long names. Right? The last kind of tinea capitis is this, which already some of you have mentioned. It is favus. It forms crust, cup-shaped crusts called as scutula. The causative organism is Tisch conleni. And here again, Wood's lamp will be positive. Okay, so please remember these important points about different types of tinea capitis. Clear? What is this crust? This crust is nothing but inflammation, the keratinocyte debris and fungal colonies. Right? Okay, great. So next, I'll give you a brief history and then tell me what do you see. A 13-year-old child presents to you with numerous monomorphic erythematous small plaques which are slightly scaly on the trunk. The mother gives history of sore throat 2 weeks prior to development of these lesions. What is the most probable diagnosis here? Please listen to the history that I gave you before answering the question. The child presents with multiple monomorphic red colored or erythematous small plaques which are scaly, present predominantly on the trunk, history of sore throat prior to development of these lesions. Absolutely right, most of you. This is nothing but guttate psoriasis. So just to clear doubt of people who have given me different answers, why is it not pityriasis rosea? In pityriasis rosea, you see Herald patch. First, there is development of one large lesion and then subsequently numerous lesions are formed. And here I am giving you history of monomorphic. Monomorphic is similar morphology, small lesions which are scaly after development of sore throat all over the trunk. Plus, you do not see lesions along the lines of cleavage. So, this is not pityriasis rosea. This is a typical case of guttate psoriasis where you have raindrop like lesions. So lesions are present like raindrop all over the trunk, typically seen in children. What is the treatment for guttate psoriasis? Give me that. Raindrop like, it's not raindrop like pigmentation. The lesions are present in raindrop distribution. Multiple small monomorphic lesions present on the trunk, present in children. History of streptococcal infection, some form of streptococcal infection. Usually they give you sore throat, which is there in the past. So this is a special type of psoriasis called as guttate psoriasis. Here the lesions are not large, not very scaly, predominantly on the trunk, seen in children. What is the treatment of choice here? Yes. Okay, so Dr. Aradhana, steroids are not given in psoriasis ever, except for one condition now. Since you started it, which is one type of psoriasis where you use steroids? Give me the answer to that. For this, yes, you are right. The treatment would be macrolide antibiotics. So you give antibiotics here because it is thought that guttate psoriasis is actually flared up by streptococcal infection. So if you treat it, guttate psoriasis corrects itself. Yes, absolutely right. In psoriasis, you never give steroids except in pustular psoriasis of pregnancy, which is also called as impetigo herpetiformis. So there we cover another question. Otherwise, never ever mark oral steroids for psoriasis. Right? Now, since we are discussing psoriasis, quickly using the time to cover other important topics. So what is positive in psoriasis? What is this test that I see here? So this is Koebner's phenomena. Koebner's phenomena, you all know, along the site of scratching, you develop lesions of similar morphology. You should know true Koebner's is seen with psoriasis, vitiligo and lichen planus, and pseudo Koebner's is seen with pseudo-Koebner's is seen with warts and molluscum contagiosum. So Koebner's phenomena, or it is also called as isomorphic phenomena, is when you develop lesions along the sites of trauma, along the sites of scratching, and true Koebner's is seen with psoriasis, vitiligo and lichen planus, whereas pseudo Koebner's is seen with warts and molluscum contagiosum. So since we see it in psoriasis, it is a very, very important thing. Okay, what is the test? What is the bedside test which is done for psoriasis? The bedside test which is done for psoriasis, quickly. Okay, Dr. Vigneshwar, we do not see pseudo Koebner's in varicella. We do not see pseudo Koebner's in chickenpox. Okay, so warts and molluscum contagiosum. With diarrheas, it is still controversial. Okay, so if you have option, please mark warts or molluscum as your first preference. Do not club it with varicella or diarrheas. With diarrheas and pemphigus, it is occasional Koebner's which is seen. Okay. Okay, so when I ask you bedside test, please don't say Gretard's test, always say Auspitz sign. They can give you both of them in the exam to confuse you, so that is why I asked this question. Gretard's test is a part of Auspitz sign. So the more precise answer would be Auspitz sign, where you see pinpoint bleeding points when you scrape it with the slide. So Auspitz sign would be my preferred answer. However, if it is not there in the choice, then you say Gretard's test. Gretard's test is also right, but it is just a part of the whole test. Clear? Then, in psoriasis, the other questions that is asked is, what is the most common nail finding that you see? Okay, you all would know that. I'll change the question. What is the pathognomic nail finding seen in psoriasis? What is the pathognomic nail finding which you see in psoriasis? Yes, so you are right. The pathognomic sign is this, oil drop or salmon patch. However, the most common finding that you see in nails of psoriatic patients are pits. Pits which are, remember the mnemonic drill, deep, random, irregular and large. Deep, random, irregular and large. Okay, an oil drop sign or salmon patch is the most pathognomic feature. Now, usually in the question they will give you a nail feature and you will be asked to differentiate between nail psoriasis versus onychomycosis. So, quickly revising with you, onychomycosis is fungal infection of the nail plate. So, there you see yellowish discoloration, crumbling. You do not see pits. You see pits and oil drop sign only in psoriatic nails. Then psoriatic nails usually have more than one nail involvement, whereas onychomycosis is usually a single nail involvement. Onychomycotic changes are more commonly on toenails, whereas psoriatic changes are more commonly seen in fingernails. There is no rule, but these are the most common differences. Then how do you differentiate? If you do a KOH, you would see a positive result in onychomycosis and negative in psoriatic nail. In psoriatic nail, what we do is onychoscopy, or we do dermoscopy of the nail plate and we look for these changes that we already discussed. Okay, so you should be able to differentiate between an onychomycotic and a psoriatic nail. Usually pitting or salmon patch is an important differentiating feature, right? The treatment, okay, yes, treatment for onychomycosis would be terbinafine or itraconazole. For psoriatic nail, if it is a single nail involvement, we give intramatricial injections. However, if it is a part of generalized psoriasis, you treat the psoriasis in general. Now, since we are talking about psoriasis, quickly, because in histopathology there are few topics which are asked. So, histopathology of psoriasis is something that you should be knowing. Important features, they give you this image and they ask you what is it the histopathology of. Since I already told you we are discussing psoriasis, so I'll quickly tell you the important pointers. Parakeratosis is something that you see here. Parakeratosis, you all know, is retention of nuclei in the stratum corneum. They also ask you parakeratosis is seen in what all conditions do you see parakeratosis in? You see it in P's 2. Remember the mnemonic P's 2. Psoriasis, eczema, actinic keratosis, seborrheic dermatitis and SCC. Actinic keratosis is something which had come in the exam in the past. So, I know I am going here and there, but it is a last resort revision as we call it. So, I am trying to revise the maximum points here. So, parakeratosis is commonly seen in psoriasis. Absence of granular layer or agranulosis. There are a lot of features. I am only discussing the important ones here which you are telling me. Munro's microabscesses. Munro's microabscesses are nothing but collection of neutrophils where in stratum corneum. The other kind of microabscesses that you see are Kogo's spongiform pustules, but they are seen in stratum spinosum. So, they mark, they put you a collection of neutrophils and they mark and they ask you what is it, and they will give you Munro's microabscesses and Kogo's spongiform pustules. So, remember, Munro's microabscesses are there superficial, they are stratum corneum. Kogo's spongiform has S, it is present in stratum spinosum. So, agranulosis, parakeratosis, presence of these microabscesses, and then what is the appearance of rete ridges called? What is this appearance of rete ridges called as? Yes, you are right, it is called as club shaped rete ridges or also called as camel foot appearance. Camel foot appearance or clubbed shaped rete ridges are typical feature of psoriasis. And then there are a lot of other features, there are dermal thinning and other things, but these are the important things that you are usually asked. Wedge shaped hypergranulosis and sawtooth rete ridges. Where do you see them? Wedge shaped hypergranulosis and sawtooth Rete ridges, where do you see them? Another question. Very good. So lichen planus is another papillosquamous disorder, but there the difference is there is hypergranulosis, which is called as wedge-shaped hypergranulosis, and rete ridges are sawtooth. There are a lot of other differences, but these are the two important ones that you should be knowing. Sawtooth rete ridges which appear like this. Okay, and there is a band of infiltrate which is present in lichen planus. Clear? So this is in brief about histopathology of psoriasis. Quickly, I want to discuss the treatment of psoriasis for you. So treatment of psoriasis, if I am talking about guttate psoriasis, it is antibiotic. If I am talking about impetigo herpetiformis, it is steroids. Otherwise, what are the common drugs which are used for psoriasis? The most common drug which is used is methotrexate, which is my treatment of choice for most of the other psoriasis like erythrodermic psoriasis, psoriasis with joint involvement, plaque psoriasis. All of this I use methotrexate as my drug of choice. The other drug that we use is acitretin. Where will you mark acitretin as your drug of choice? In pustular psoriasis and in patients with HIV positive psoriasis. Patients who are HIV positive and have psoriasis, there my treatment of choice will be acitretin. So these are my drug of choice for psoriasis. However, what are the other treatment modalities that you can use? You can do phototherapy, where I prefer NB-UVB therapy more than PUVA. You can control the acute crisis. What is the crisis drug in psoriasis? Which drug do you use if the patient has acute onset psoriasis which has flared up and I want to control it? Cyclosporin, you're right. So cyclosporin is a crisis drug for me. Then there are numerous biologicals which are now available for psoriasis and you should briefly know about them, right? So this is about treatment of psoriasis. There are two more questions that had come and I wanted to discuss it with you. So patients suffering from chronic plaque psoriasis with more than 50% body surface area involvement, which of the following is not used? Though I have emphasized it earlier, please remember prednisolone is not used. NB-UVB, coal tar, cyclosporin, all are the treatment of choice for treatments which can be used in psoriasis. Then another important question, which is a true association? So true association, so remember psoriasis is being increasingly recognized to be associated with metabolic syndrome. So this has been asked twice. Metabolic syndrome is seen to be associated with psoriasis. So any psoriatic patients you should evaluate for metabolic syndrome. Clear? There are a lot of biologicals which are available. In India, we have etanercept. Most commonly we use secukinumab. I'll quickly give you a name because they may ask. Secukinumab is what is used and this is an IL-17 inhibitor. It is a IL-17 inhibitor. There is another drug in the same class which have come up since last year which is called as ixekizumab, which is also now available in India. Since this has been recently available, they may ask you about it. It is also an IL-17 inhibitor. It is specifically IL-17A inhibitor. Yes. So secukinumab and ixekizumab, both of them are IL-17A inhibitor and they are more commonly used as biologicals now, right? Okay. So moving on to the next topic now, you can get an image like this where any of these images would be given. I'm sure you would be able to know, you are able to know that we are talking here about contact allergic dermatitis. I want you to quickly give me the agents responsible for these three figures. Yes, you all know that this is allergic contact dermatitis. Till you give me the agents, the exact chemicals which are responsible for each of them, quickly I will tell you that when you are dealing with allergic dermatitis, you have to differentiate between irritant and allergic dermatitis. So irritant dermatitis is something which happens instantaneously. There are no memory T cells here, right? Whereas allergic dermatitis happens on second exposure to the chemicals, because the first exposure leads to development of memory cells, and then you will develop an allergic reaction on subsequent exposure. Now here I have images of different contact allergic dermatitis. So let's see quickly. Absolutely right. What is this third one? You are all right. Nickel is responsible for this, and nickel is the most common agent which causes contact allergic dermatitis. So most common agent causing CAD in India is nickel dermatitis. And where do you find it? Rubber belts, rings, and things like that, wristwatches, so everywhere. This is bindi dermatitis, and the common allergen which is present here is para-tertiary butyl phenol. You're all right. PTBP. What is this? Okay, Dr. Prashant, it is not leukoderma. Please look at the image. In leukoderma, you will get a white patch. You can get a contact leukoderma with bindi, but here it is not contact leukoderma. It is a contact allergic dermatitis, because you see red, crusted, oozy lesions here. Okay. The last is hair dye, and here the agent is paraphenylene diamine, or PPD, which is the most common allergen which is present in hair dye. So usually in CAD they can ask you the diagnosis, or they ask you the agents, or they ask you how to treat. So how to treat is, the most important is avoid contact. Avoid contact with the relevant antigen. Okay, what is the agent? If I give you a history, a cement worker presents with allergic dermatitis. So in cements, what is the common agent? Quickly tell me, because these are the common questions which are asked. A cement worker, if they give you any history of cement worker developing allergic dermatitis, so what is the most common chemical involved? It is chromate. Absolutely right. So potassium dichromate or chromate is the agent which is present in cement workers. So you should know. Quickly, what test will you do? What test will you do for them? If I have to do a test to diagnose, what test will you do? Contact allergic dermatitis, what test will you do? Quickly. Absolutely right. You would do a patch test. So patch test, you should know everything about patch test. They ask you various questions. So in patch test, the first question that is asked is, it is used to diagnose. So it is used to diagnose CAD. What type of reaction it is? It is a delayed type of hypersensitivity reaction. Where do you do the patch test? You do it on the back. Okay. What is the ideal time to read a patch test? Tell me this. What is the ideal time to read a patch test? Okay, I'll give you options. B, C, D. 24 hours, 48 hours, 96 hours, 48 and 96 hours. A, B, C or D? Quickly. Okay, so lot of different answers. The best answer here would be answer D, 48 and 96 hours. If they are given, you should mark this. However, if I did not have D as a choice, my next best answer would be C. So this would be my first answer. If this is not given, then I'll mark 96 hours. See, the aim of doing the patch test is to identify all the allergens. There are a lot of delayed reactors which becomes positive after 96 hours. So if I have to mark one, I will mark 96 hours. But if I have been given an option of 48 and 96 hours, it is not written or. So it is best to do check at 48 hours and then again check at 96 hours, because early reactors would show positivity at 48 hours and late reactors would show positivity at 96 hours. Why not just mark 96 hours? Because the early reactors reaction may diminish in 2 days. It may diminish, so you may not see the severity of reaction by 96 hours. So the best answer would be 48 and 96 hours. So please don't get confused and mark this as an answer. Okay, great. So Most commonly, you're right, we read it at 48 hours. The best is 96 hours, but if 48 and 96 both are given, mark this. Okay, so this is about patch test and you should be knowing about this. Okay, treatment for contact allergic dermatitis, it is very simple. Avoid the causative agent, use occlusions, use protection, like you can wear gloves, you cannot change occupation, so you wear gloves, you wash your hands after coming back from your work, and you use topical steroids along with antibiotic combination. If it is very severe, you can give oral steroids also. There was once a question, you never use retinoids in contact allergic dermatitis. Okay, so there was question what cannot be used. So retinoids is something that you do not use in contact allergic dermatitis. Clear? Okay, so this is my next image. A 3-month-old child presents, you get a derma referral, you go to the ICU, you see a 3-month-old child who had otitis media to begin with, and suddenly he developed extensive denudation of skin all over his body. This is what you see. Okay, so it is SSS, don't confuse it with ichthyosis or SJS10. That is why it is very important to listen to the history that I am giving you or the question that is given in the exam. I said a 3-month-old child who is in ICU. There is a history of otitis media. I mentioned that. The patient is febrile and there is extensive denudation of the skin. SJS10 is very rare in this age group of child unless they've been exposed to antibiotics. Ichthyosis will present more as colloidal membrane, not as denudation of skin. So please don't get confused. This is a case of SSS. What is the toxin which is involved here? So SSS is Staphylococcal scalded skin syndrome. It is a toxin mediated disorder. You had an infection with Staphylococcus, a prior infection of Staphylococcus, the toxin is released in the blood, it goes and binds to desmoglein 1, causing peeling of the skin. And so yes, here you can see a positive Nikolsky sign. What is the toxin? I asked you that. Yes, you're right. It is called as epidermolytic toxin 1 or exfoliative toxin. Exfoliative toxin or epidermolytic toxin 1, and it targets desmoglein 1. So previous history of staphylococcal infection would be there. It may or may not be there, but usually they tell you, and it is caused by the toxin which has been released in the blood. It will go and bind to desmoglein 1 and cause excessive peeling of the skin. Nikolsky sign may be positive. Thank you, Dr. Shivam. Yes, it is also called as Ritter's syndrome. Please don't get confused. Ritter's disease is something else. Ritter's is R-E-I-T-E-R. Ritter's syndrome is a type of usually a type of STD or sexually acquired reactive arthritis. This is Ritter's, R-I-T-T-E-R, right? Good. Okay, now what is the type of lesion and what is the most common cause? This is what they will ask you here. Okay, so what is the confusion? SJS10 we already discussed, Dr. Aditya. In SJS10, it is caused by drug. There is, okay, so if you're confused, why cannot be SJS10 is caused by drug. Second, very important point about SJS10 is there is 2 or more mucosal involvement. SSS may not have mucosal involvement. So mucosal involvement, drug is very, very important. The pathology is different. Here it is caused by toxin. There it is caused because the drug is causing keratinocyte necrosis and apoptosis. Okay, so there you will see more of crusted oral mucosa, genital area will be involved. There will be a history of drug intake. Okay, I hope that's clear. Okay, very good. So yes, what we see here is target lesion. Dr. Pooja, this is not Lyme's disease. Lyme's disease caused by Borrelia has a different kind of lesion. Look at the lesion here. There are 3 zones. There are 3 zones. This is a typical target lesion and you see it in YouTube पे नहीं चल रहा. मेरा तो जा ही नहीं रहा मैसेज, ये भी स्टक हो गया। क्या हो गया, चैट भी नहीं चलेगा तो कैसे होगा, फोन ही हैंग हो गया। फोन बंद हो गया, क्या हो रहा है आज, फोन का टेम्परेचर बढ़ गया। यार है लिखा हुआ, कर दो कोई बात नहीं। हाँ क्या, it's stuck. पूछो, you're live मैम। क्या है, देखिए it's okay, live screen। You guys hear everything, I guess. Hello everyone, I'm back. Yes, there was some AC तो चला हुआ है, पर टेम्परेचर फिर भी बढ़ रहा है। शायद क्लास अच्छी चल रही है। आई थिंक वी आर ऑल स्वेटिंग अप to increase the temperature. Okay, getting back guys, so I'm so sorry there is some technical glitch that happened, but don't worry, we'll try to finish up soon, and I'm back with you guys. iPhone ही है, बाकी आप लोग दिला देना अगर और दिलाना है तो। फिर स्टक हो गया, is it stuck again? मैसेज कर लीजिए। Guys, am I visible? Am I audible? Okay, great. So thank you very much. So let's start again. And so we were talking about target lesions. Now fine. Okay. So I guess now I'm audible and visible. So we'll quickly start before we have another glitch. So target lesions is seen in erythema multiforme, and some of you gave me the answer. Yes, the most common cause is HSV followed by mycoplasma. So virus is the most common cause. Drugs can also be the cause, but the virus is the most common cause in virus HSV. Okay. Now, another important thing that they ask you for target lesion, they do not sometimes give you a direct question. They say a patient has recurrent herpes genitalis or a patient has recurrent herpetic gingivostomatitis, and now the patient presents with this kind of a lesion. So you should know that HSV can lead to target lesions, and so you should be able to identify them. This is not a bullseye appearance which is seen in other disorder. This is typical target lesion where you see three zones: a central zone of crusting, edema, and then erythema. Okay, how to differentiate from fixed drug eruption? Okay, fixed drug eruption will not have three zones. Okay, so fixed drug eruption will have, you will have a round lesion which is erythematous, and you may see small pustules at times. And most important, when they give you an FDE, they will usually give you, what I've seen in exam, they give you a pigmented FDE. So you see on lips or on glans penis, they'll give you a pigmented lesions. Okay, and they will give you a history that it recurs at the same site always. Okay, so that is another history that you will see. Okay, so moving on. Next, I have listen to the question, guys, since my audio is clear. So there is a farmer who presents with these lesions on his arms or legs, and so they can ask you what is the diagnosis, what is the causative agent. So what is the diagnosis first of all? So absolutely right. Somehow examiners are really fond of this topic, and I see this coming very frequently. You're right, this is sporotrichosis. Important pointers or important questions that are asked is a farmer or a rose gardener, because it is typically also called as road gardener's disease, presents with linear distribution of lesion, which is also called as sporotrichoid pattern. Typically, dermal nodules or crusted plaques are present in linear distribution, and it can be a farmer or rose gardener who is presenting with it. So this is what this is, sporotrichosis. Why is the distribution linear? Because of involvement of dermal lymphatics. What is sporotrichosis? It is a type of subcutaneous fungal infection, so which is infecting my dermal lymphatics, and since dermal lymphatics are linear, the lesions are present in linear distribution. The next question, what do you see on histopathology, which you all have given me answer? You see something which is called as asteroid bodies. Asteroid bodies, they are basically fungal elements and the surrounding inflammatory cells, which gives it a star-shaped structure called as asteroid body. What do you see on pars stain? What do you see on pars stain? Very good. You guys know everything. I'm so glad. Cigar bodies. So pars stains, you see cigar bodies. What is the phenomena called as? These formation of asteroid bodies, it is called as Splendor-Hoppley's phenomena. Remember, Splendor-Hoppley's phenomena is seen with some other disorders also, sporotrichosis being one of them. Very good. I was coming to treatment. So what is my treatment here? Potassium iodide is correct. What other treatment can you use if potassium iodide is not there in the option? If potassium iodide is not there in the option, what other option can you do for treatment? So one is potassium iodide and second is itraconazole. Itraconazole can also be used as treatment, right? What are the other types of subcutaneous mycosis you should be knowing of? Quickly revising with you. Mycetoma. Mycetoma will present on foot. There will be numerous discharging sinuses from which grains will be coming. There will be tumefaction. A farmer would be given again, and it would be usually a painless swelling of the foot which will be given, right? So mycetoma is another subcutaneous mycosis that is commonly asked. So quickly I have told you the important pointers, how to differentiate between them. Yes, mycetoma can be differentiated into actino and eumycetoma. I will not go into the details of that. Now, coming to the basics. When we talk about basics, typically in the exam, you are given an image like this and a cell can be marked from the epidermis and you have to identify that cell. So since the time does not permit much, I will quickly revise with you what are the different cells that you see in epidermis and the important questions which are asked. So the maximum contribution of epidermis is by keratinocytes, which form almost 90% of my epidermis. Keratinocytes are present all over in all layers of the epidermis and they are derived from ectoderm. They are derived from ectoderm. The second cell in the epidermis is melanocytes. Okay, quickly a question. What is epidermal melanin unit? What is the ratio of cells in an epidermal melanin unit? Okay, so melanocytes are present where? Only in stratum basale. On the basal layer, we have, in between, we have melanocytes. Melanocytes are derived from neural crest. M is derived from N. M is derived from N. Next, M is Merkel cells, which are slow adapting touch receptors. There is a confusion from where they are derived. So some people say ectoderm, some people say neural crest. If they are both there in the question, you should mark the ectoderm. However, it should not come. Where are Merkel cells present? Again in stratum basale. So both M's are present in stratum basale. Absolutely right, all of you. 1:36 is my EMU. I'll come to that. The last layer is the Langerhans cells, which is derived from mesoderm. And where is it present? It is present in stratum spinosum. So these are all keratinocytes. This is a Langerhans cell present in stratum spinosum. This is a melanocyte, which is a pigmented cell, and then there are Merkel cells which are attached to the stratum basale. Merkel cell are slow adapting touch receptors. Okay, now important points again. Keratinocytes form important, it is the whole structure of epidermis is formed by keratinocytes. They are connected by keratin intermediate filaments. Melanocytes are pigment forming cells, and so each melanocyte supplies melanin to 36 melanocytes, and that is why we call it as 1:36 ratio for EMU. Now remember, melanocytes are present in the basal layer. In the basal layer, they are present in the ratio of 1:10. So 1 melanocytes for every 10 basal cells. However, each melanocyte transfers its melanin to 36 keratinocytes, which is EMU or epidermal melanin unit, right? EMU is very, very important, and so that's why I discussed with you here. Langerhans cells are what? Langerhans cells are antigen presenting cells. These are antigen presenting cells which are present in stratum spinosum. Now Langerhans cells have a particular type of granules. Okay, you have already told me. Langerhans cells have Burbeck or racket shaped granules. So you can be given an image like this, which will be bluish in color. So Burbeck granules or racket shaped granules are seen in Langerhans cells. And so sorry guys, I'm really sorry for the video getting stuck again and again. If you miss out on something, you can tell me, I'll get back to you. Tennis racket appearance or Burbeck granules. So sometimes they give you an image of Langerhans cell, they give you Burbeck granules and ask you what granules they are. Then you also told me that yes, what are the markers? CD1A, CD207 are seen here. Right, absolutely right. Okay, so you should be knowing about all these cells which are there in the epidermis, what is its location, where are they derived from, and what are their important functions. Okay, I have next this image. I have an image of a person who's coming from Bihar, who presents with this light colored lesion, hypoaesthetic lesion on the trunk. Okay, now listen to my question carefully. I have a resident from Bihar. Obviously, it's leprosy. As soon as I say hypoaesthetic, you know it is leprosy. Now, I want you to tell me the spectrum of leprosy. Now, my options are B, C, D, B, L, B, T, 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 or B, B. So, what is this spectrum? And why? So you all are right, this is borderline tuberculoid leprosy. Now you tell me why. Why did you say this is BT? Features. So if I have TT, if they want to ask me TT, they will tell me few things. There would be usually less than, there would be a single lesion, and there will be 100% loss of sensation. TT has 100% loss of sensation, and the description is called as saucer right way up. TT is rarely asked. Okay. Next is BT. BT has pseudopodia and satellite lesions, 1 to 10 lesions. Next is BB. BB is very unstable kind of leprosy. Here you have geographic or map-like configuration. Geographic or map-like configuration. Then we have BL, What is the classical feature of BL Hansen? Okay. I think the video got stuck, so I'll quickly start again. I was talking about various spectrums of leprosy. So, and just giving you important pointers how to differentiate between spectrums, because they give you a question and they give you various spectrums. So, TT is the topmost highest immunity. So, in TT, the number of lesions will be very few, and there will be 100% loss of sensation with loss of hair, loss of sweat glands, so very dry lesion. The appearance is called as saucer right way up. The next is BT. In BT, I already told you, you have pseudopodias and you have satellite lesions. The number of lesions is 1 to 10. BB is the most unstable form of leprosy, where you see geographic or map-like configuration. My leprosy is trying to spread here. So you have geographic or map-like lesions. BL, you are right. I see inverted saucer appearance, and you're absolutely right. The lesions now tend to become symmetrical. You don't exactly need to remember everything. If you understand leprosy, this will be very easy. Just know the names. So, BL has inverted saucer appearance, and here the lesions tend to be symmetrical. What is the type of anesthesia that I see in BL leprosy most commonly? What is the kind of anesthesia that I see? So, lesional anesthesia is minimal, but what is the type of anesthesia that I see in BL Hansen? Glove and stocking anesthesia, absolutely right. So here my involvement is now extending to peripheral nerves, so I start getting glove and stocking anesthesia. LL Hansen will present with leonine facies. There will be extensive infiltration, and you will see leonine faces, you will see symmetrical lesions all over, and you would see glove and stocking anesthesia. Most commonly they ask you BL, BB and BT. These are the three most common spectrums that are asked. Now, can you give me other DDs for satellite lesions? Obviously, one is BT Hansen. The other DD that is there for satellite lesions is candidiasis. Remember, candidiasis also has satellite lesions. So, if there is an intertrigo which is given and you see satellite lesions, remember candidal infections have satellite lesions. The third DD of satellite lesion is sporotrichosis. Okay, so sometimes once they'd ask this, so satellite lesions are seen with all these conditions. Why have we come to P versicolor and all? Please, there is no correlation here with P versicolor. No, P versicolor will not present with a single lesion, with satellite lesions or pseudopodia. We'll discuss P versicolor subsequently. I have a question of that too. This is not P versicolor. You can see a plaque, a proper plaque with pseudopodia with satellite lesions. Don't get confused here, okay? Now, moving on, in leprosy, somebody was asking me about reactions. So, we have two reactions and you should be able to differentiate between the two, okay? So, here this is type 1 lepra reaction and this is type 2 lepra reaction. Quickly, I will tell you the important pointers. Type 1 reaction is also called as upgrading reaction. It is seen typically in upper spectrum of leprosy, whereas type 2 is seen in lower spectrum of leprosy. So, lepromatous pole, you see type 2. This is also called as ENL. Type 1 is a type of type 4 hypersensitivity reaction. This is a type of type 3 hypersensitivity reaction. Okay. Then here you see the existing lesions, they become more inflamed, more tender, more red. Whereas here you see new crops of lesions. New crops of lesions are coming. This is also associated with nerve abscess or new onset neuropathies. Basically, please understand that type 1 is my body's immune reaction against the bacteria, which are being degenerated because of starting of MDT. When you start MDT, the bacteria dies, and the bacterial antigens that are released, my immune response mount an immune response, my immune system mounts an immune response against it. So the existing lesions will become tender, red, erythematous, nerve involvement will be there. So typically a history of starting of MDT will be there, lower upper spectrum would be there, and these will be the important features. Whereas ENL reaction occurs because there is so much load of bacilli, so a type 3 or antigen antibody reaction develops against this. This is seen in lower spectrum. You see newer crops of lesions. You see lots of constitutional symptoms like evening rise of temperature here. Here there is evening rise of temperature, and with evening rise of temperature you see development of new crops. Okay, any questions? Okay, so here now the important question that is asked is treatment. So one, you should be able to identify, differentiate between type 2 and type 3. Even if you are not able to differentiate, please remember treatment for both is steroids plus continue MDT. Very, very important question. Sometimes students get confused, oh, whether it is type 1, type 2, what should I mark? If you're not able to differentiate, please don't worry. The treatment for both remains steroids plus MDT. Now, lot of you are confused that whether for type 2 reaction we should mark thalidomide or steroids. Please remember, your first choice should be steroids. You can mark thalidomide only if in question it is written that the patient is highly diabetic, patient is steroid unresponsive. So if there is any situation in which you cannot give steroid to the patient, there my thalidomide becomes my drug of choice. Otherwise, steroid is the drug of choice for both types of reaction and continue MDT. Please remember this, okay? So, even if you're not able to differentiate, write steroids and continue MDT. And, I can use that. And if it is not responding, if you cannot give steroids, then you give thalidomide, okay? What is the treatment of nerve abscess? Quickly tell me that. Somebody told me to change the color. So is this better? I can change to any color that you like. I don't mind that. If the patient develops nerve abscess, what is the treatment? I'll give you options. Will you give steroids? Will you drain the lesion? Will you give anti-inflammatory? Quickly. 3 options only. Drain, steroids, anti-inflammatory. Treatment of nerve abscess. Am I stuck again? I'm not getting any responses. So again, in question, if it is asked, the treatment of nerve abscess, it is again steroids. Draining is, why is the abscess formed? Abscess is formed because of the intense inflammation. So you give steroids plus NSAIDs, but again, my drug of choice is steroids here. Okay, so if steroids are there in the option, please write steroids. Draining is not necessary if it corrects with steroids, right? Good. Next question, give me the answer. Which nerve is biopsied for diagnosis of neuritic leprosy or pure neuritic leprosy? Another important question which people get confused with. So pure neuritic Hansen, I'll quickly tell you, is a type of Hansen that typically is seen only in Indian classification. Here you do not have any lesions, but nerve involvement is present, and that is what is manifested. So amazing, very good all of you. Please don't say ulnar nerve, please don't say median nerve, please don't say this. Answer is this. Please remember, whenever you are biopsying a nerve for neuritic leprosy, you have to do it from a nerve which is strictly sensory in nature. Because if you do a biopsy, you do not want motor paralysis. So you do a biopsy from a nerve which is strictly sensory in nature, superficial branch of radial nerve, and so is the answer, because this is one nerve which is sensory in nature. If if you do not have this option and you have sural nerve option, you can mark that too. If you have both as option, then again you would prefer radial cutaneous nerve to sural nerve because it is more easily accessible for biopsy. So for a neuritic Hansen, it should be radial cutaneous nerve. If not present, then sural nerve. Okay. Yes, sural nerve is possible. I'm telling you, if both are there in the option, then you mark RCN. Right. So next in leprosy, you should know about these blister packs. You should be able to identify. Now we use only 2 blister pack. This is for adults and this is for kids. If it is MB leprosy or PB leprosy, the treatment remains the same. The only difference is duration. For MB you do 12 months, for PB you do 6 months. The treatment remains the same, which is rifampicin, clofazimine and dapsone, monthly dose and daily dose. So rifampicin monthly 600 milligram, clofazimine monthly 300 milligram, clofazimine 100 milligram daily and 50 milligram daily and dapsone 100 milligram daily. So rifampicin 600 उसका आधा 300, dapsone 100 daily उसका आधा 50 milligram. Clear? You should know these doses. You should know these doses. However, if I have a kid, what can I do? Rifampicin becomes 450 milligram, clofazimine becomes 150 milligram, this becomes 50 milligram alternate days and dapsone becomes 50 milligram. Right? It is not very difficult to remember. So you should know the treatment of leprosy, you should know the duration of therapy. So Dr. Naveen, now we use this pink blister plaque only, whether it is MB or PB. MB 12 months, PB 6 months. Please remember this, okay? Okay. Moving on to the next very important topic, you can get this, mostly you get this image. You tell me the diagnosis of this image and how will you treat? How will you treat the image that is present on the, which I have ticked, what is it and how will you treat? Quickly. I am talking about this image because this is what you usually get. Yes, this is impetigo. Tell me what kind of impetigo it is. I know you all know this is impetigo. Please don't say lupus vulgaris. You are seeing bulla, you are seeing crusted erosions. This is not lupus vulgaris. Okay, what's the confusion? Why am I not getting more of impetigo contagiosum or non-bullous impetigo? Okay, so this is an image of impetigo which most of you are clear about. I have put 2 images of impetigo. This is bullous impetigo and this is non-bullous impetigo, which is more commonly asked, also called as impetigo contagiosum. Impetigo contagiosum. Okay, now this is caused by strep, can also be caused by staph, but strep is the more common cause. This is caused by staph. Okay, important question that is asked here is, here you see honey colored crust. Honey colored crust, if present in the question, if given in the image, you know this is impetigo contagiosum. So you see these crusted erosions. Any confusion? And what do you do? What test do? You do a gram stain and you see gram negative cocobacilli. What treatment do you do? Treatment is you give topical antibiotics, and if it doesn't correct, then you give oral antibiotics. Usually it corrects itself by topical antibiotics. Okay, non-bullous impetigo is usually seen in toddlers, bullous is seen usually in infants. What is one complication that can be associated with non-bullous impetigo? Quickly, there was once a question. What is the one complication that can be seen with non-bullous impetigo? So it is post-streptococcal glomerulonephritis because it is caused by streptococcus. So PSGN is a known complication. In bullous impetigo, what is the target antigen? In bullous impetigo, what is the target antigen? Good, you all know this. So target antigen is desmoglein 1 here, and the staphylococcal toxin targets desmoglein 1, and there is formation of bulla. Not desmoglein 2. No, it's not BP antigen 2. Please don't get confused. It is desmoglein 1. We just discussed staphylococcal scalded skin syndrome. So staphylococcal toxin targets desmoglein 1. Remember like that. Okay. Another important question. I know you all know this is erythrasma. My question to you is, the fluorescence that you see here is because of what? What is this kind of fluorescence? And it is seen because of what? So you would get a patient who would have these things on his underarms, and probably the options that will be given would be tinea cruris, intertrigo, erythrasma. Because I give you this image, it is very easy to diagnose that this is erythrasma, because I am seeing a positive coral red fluorescence here, and you all are right, it is because of coproporphyrin 3. What is the causative organism? Coproporphyrin 3. So erythrasma is caused by Corynebacterium. It is a bacterial infection, not a fungal infection. It is caused by Corynebacterium, and specifically Corynebacterium minutissimum. I am not writing the whole name. So Corynebacterium minutissimum, which is a bacteria, is the main cause. How do you differentiate it from tinea cruris? You do a Wood's lamp and you see coral red fluorescence, which is there because of coproporphyrin 3. Other Corynebacterium infections that you should be knowing about is pitted keratolysis. So Corynebacterium can also affect the feet. That is caused by Taenius, Microsporum taenius. It is seen on feet. You see pitted keratolysis. KOH will be negative here. For tinea, you would do KOH. For this, you would do a Wood's lamp fluorescence, right? Okay. 18 months old child is brought by mother with these lesions on the trunk. The child is usually irritable, itchy. My question to you is, what is this sign that I have depicted here? What is this sign that I have depicted here? Sorry guys, I think I'll go a little quicker because I want to cover more topics. So you are right, this is cutaneous mastocytosis. Which type? Dr. Vigneshwar gave the right answer. This is urticaria pigmentosa. Now, what is the sign that I am seeing here? So, it is urticaria pigmentosa. It is a type of cutaneous mastocytosis that you see in usually in 2 years children. And there is a sign, absolutely right. This is Darier's sign. So what is Darier's sign? So since this is cutaneous mastocytosis, if on the lesion I stroke it with the blunt end of my pen or a key, I see an urticarial lesion developing around the lesion. This is called as Darier's sign. Darier's sign is not seen in Darier's disease. It is seen in urticaria pigmentosa, where a child presents with hyperpigmented lesions on the trunk, which if you stroke with the blunt end of the pen or key, you see a positive urticarial reaction, which is called as Darier's sign, right? So this is another question which is commonly asked. This is all that is asked in urticaria pigmentosa. Okay, so moving on, I have a 16-year-old male who presents to me with recurrent lesions on the trunk. Patient typically gives history that the lesions come during hot humid weather. They are usually asymptomatic. Good, you all know this. So what I am telling you in the question is all the important pointers. You know this is pityriasis versicolor. Important pointers here are, okay, my question to you, I know you all know P versicolor, don't write that. My question to you is, the hypopigmentation that you see is because of what? The hypopigmentation that you see here is because of what? So it is a type of superficial fungal infection caused by Malassezia furfur, Malassezia globosa, and it is seen in hot humid environment. Recurrence is a rule usually seen in adolescent age group. But I am asking you, my question to you was, what is the hypopigmentation due to? Perfect. So the hypopigmentation, versicolor means various colors because the lesions can be hyperpigmented or hypopigmented. Hypopigmentation in these lesions is because of production of azelaic acid, or in the exam they can also write carboxylic acid. So hypopigmentation on the lesions is because of production of azelaic acid or carboxylic acid. Okay. Then you have to remember what is the treatment. Treatment is you give topical antifungals. However, if it is more severe, you can give oral antifungals. What class of antifungals will you use? Azoles. However, there are other agents that can be used like selenium sulfide, zinc pyrethron. Yes, good. So, if there is any azole cream, clotrimazole, luliconazole, sertaconazole, anything with azole, you can mark that. But if there is no azoles, you can also mark selenium sulfide, zinc pyrethron, or even sulfur. So there is no azole in them, but they are also used as treatment for pityriasis versicolor. Yes, you already told me this. There is spaghetti and meatball appearance, and there is positive Woods lamp fluorescence, which can be seen with in P versicolor. Right? Okay. I have the next question is this. Guys, is the speed fine? Are you, is the session okay? If you are enjoying the session, don't forget to like and subscribe. And moving on to the next question. Okay, so this is a male who presents with the, okay, great. Guys, you guys are super intelligent. Even before I tell you the question, you give me the answer. So, yes, so this is tinea incognito. So, why have I given you this? So, commonly in the exam, the question comes, a patient presents to you with a lesion on the thigh, and the patient has used multiple OTC products, and this is now what it is not improving. You do not see a classical annular scaly lesion. What you see is a lesion which has lot of erythematous papules, hyperpigmentation. Hint here would be use of OTC products or use of steroids. So, usually these patients are patient of tinea corporis who have used steroids, and because of steroids the picture has become modified and now it has become tinea incognito or hidden tinea. Like you go in incognito mode, so here the tinea has gone into incognito mode. So the important thing in the question would be that the patient has used lot of OTC products or patient has used steroids. So tinea incognito will not have annular lesions, will not have scaly borders, will not show positive KOH, but a different morphology would be seen. However, the treatment would be to stop steroids and you start antifungals. Right? Okay, so this is another very, very important question that is commonly asked. Okay, next very, very important question that we get in the exam is this. Identify this. This is most commonly asked. Identify the condition that you see in the image here. Yes, this is an HPV infection. We all know we are dealing with genital warts. I am telling you to identify what name will you give to this kind of genital wart. This is condyloma acuminata, you are right. Genital warts are also called as condyloma acuminata. Okay, so genital warts are also called as condyloma acuminata. But I am asking you, what name would you give to this image? Yes, this is what they have asked you multiple times. They give you an image and they ask you what is it. This is Buschke-Lowenstein tumor. This is Buschke-Lowenstein tumor. It is a type of condyloma acuminata or genital wart, but why this is more bigger, more extensive, and so it is caused by strains of HPV which are precancerous, which are strains HPV 16 and 18. Normally genital warts, low risk HPV types are 6 and 8, you know that. High risk HPV are HPV 6 and 18, and Buschke-Lowenstein tumor is a giant condyloma acuminata. It is also called as giant condyloma acuminata. 6 and 11, yeah. Okay, so you should be knowing this. Then in warts, they can give you something like this. This is nothing but common warts or verruca vulgaris. What is this? What is this image? A history that can be given to you is a child who is on immunosuppressants is presenting with flat discolored lesions on the face. So what is the diagnosis here? This is verruca plana or plain or flat warts. This is usually seen in immunocompromised stage. Verruca vulgaris are the common warts that you see. Now, when we are talking about warts or HPV infection, the common thing that they ask you surprisingly, which I don't like, is HPV strains. So, we'll quickly discuss the common HPV strains that are asked. So, we'll write down 4, 5, 6, 7 and 8. So, first is caused, okay, I'll first give you my mnemonic, which I don't like it personally, but I think this is the best mnemonic that I could generate. Let's, oh sorry. DSP, come eat a burger. DSP, come eat a burger. I know. Sorry. If you guys have a better mnemonic, please help me out, okay? So, one is deep plantar. S is superficial plantar. P is plain wart. C is common wart. E is EDV. A is anogenital. And B is butcher's wart. Okay, so this is the easiest way that I can remember. DSP, come eat a burger. 1, 2, 3, 4, 5, 6, 7. Now you all know, we already discussed genital warts is 6 and 6, 8 and 11 are low risk, 16, 18 are high risk. With 5 you can also write 8, and the plain wart is also caused by 11. Common wart is also caused by 4, 2 and 10. However, if you remember 1 to 7, you can utilize that to answer all the questions. Okay, sorry, I by mistake wrote the 8th one, right? So, superficial, deep. So, they can give you an image and they can ask you what HPV types, and this is very commonly asked. Okay, so since we are talking about warts, we already discussed pseudococcus is seen with warts and molluscum, which you I'm sure would be able to diagnose. What are the bodies? My question to you here is, what are the bodies that you see here? Yes, this is molluscum contagiosum. You know this. This is the largest DNA virus which is available, called as molluscpox virus, and they are from the family of pox virus. Yes, this is Henderson-Peterson bodies, which are nothing but eosinophilic inclusion bodies that we see. The important feature to diagnose molluscum contagiosum is central umbilication. They are asymptomatic, and other family members would also have it. Okay. What are the treatment options for wart and molluscum? There is no oral treatment, so you have to either remove it chemically or physically. So you use TCA, KOH. For molluscum, you can do a cautery, you can do cryo. in pregnant female, okay, so this is an important question. A pregnant female with genital warts, a pregnant female with the genital warts, what are your treatment options? Pregnant female with genital warts. Give me your treatment options quickly. What all would you mark? Absolutely right. You can give cryotherapy. What else? If cryotherapy is not there in the option, TCA. Please remember this. So, a pregnant female with genital warts, cryotherapy, TCA and laser are the correct options that you can use. So, if cryo is not given, you can give TCA or you can use lasers. This is again very, very commonly asked. Okay. Another question that the examiners are fond of, a 60-year-old man presents with painful vesicles in dermatomal distribution. Painful vesicles in dermatomal distribution. What is it? Okay guys, am I back? Can you hear me? Okay, great. Thank you so much. I think internet is trying to give me breaks from speaking. So I'm so sorry guys. Let's start again. So here a lot of you gave me the answers. You all know this is herpes zoster. So remember, painful vesicles, dermatomal distribution, it will be always be herpes zoster. Now it is caused by varicella, which is the same virus which causes chickenpox. Now tell me, can this be transmitted to other family members? If I have an image of this and they ask me a question related to, can this be transmitted to other family members? Guys, can you hear me? What is it? It is a type of reactivation of latent virus. Video, is the audio also lacking? I think there is some lag in the video that I can see, but can you hear me? Good. So you are right, it cannot be transmitted to other family members, latent virus. So sometimes in the question they ask you what advice you will give. So you do not need to separate the patient from other family members because it is usually not transmitted. It is just reactivation of latent virus. The most common complication which is associated with it is post-herpetic neuralgia, which is seen usually, some people say 1 month, some people say 3 months after the infection. Okay, what is the treatment for herpes zoster? You have to give acyclovir 800 milligram. Guys, I need a thumbs up. Are you able to hear me? Are you able to see me? Okay, I will continue. If you're not able to hear or see me, please tell me on the chat box. The treatment for herpes zoster is acyclovir 800 milligram 5 times a day. So you give the highest dose, or you can give valacyclovir 1 gram TDS. They ask you this. So remember, you have to give the highest dose in herpes zoster because the patient is very painful. You need to take care of the virus. So 800 milligram 5 times a day or 1 gram 3 times a day. Okay. Moving on to the next image, I have a patient who presents to me with this white patches. Okay, are you guys with me? There's a constant lag. Video is lacking. Video is stuck. I'll let the technical team check on the video lag. Can I continue with this session till then? I will speak slowly and I'll let the image stay for a little longer. So I'll continue with the session, but and I hope the issue is fixed soon. Right, so I have a patient who presents to me with white plaques on the lateral border of the tongue. When I try to wipe it off, I am not able to remove it. What is this condition? Is it candidal infection? It is candidal leukoplakia or what? So this is oral hairy leukoplakia. Oral hairy leukoplakia is caused by, it is seen with which virus? Okay, so if I have a history of verrucous white plaques on lateral border of the tongue, and HIV positive patient, the answer would be oral hairy leukoplakia. My next question to you is, which virus causes oral hairy leukoplakia? So this is caused by EBV or Epstein-Barr virus. Okay, so these are the 3-4 important points that you need to know. Verrucous white plaques on lateral border of the tongue which cannot be wiped off, seen in HIV positive patients and caused by EBV. Since we are talking about HIV patients, there is another question that you get here. You have a patient who presents with such kind of lesions which are present on the body and the patient is HIV positive. So what is the diagnosis here? So, sorry, since there is some lag, I think I'll keep speaking so that there are no more breaks. So this is Kaposi sarcoma, again very commonly seen in HIV patients. So usually in HIV positive patients, they give you 2 questions in dermatology. One is oral hairy leukoplakia and second is Kaposi sarcoma. Kaposi sarcoma is a systemic tumor of endothelial origin. So you get these deep dermal papules or nodules which are violaceous to dark colored and they can be present in the oral mucosa or on the body. Kaposi sarcoma has 4 variants: classical, endemic, and case associated with AIDS, which is also called as epidemic case. Here you should be knowing that it is caused by HHV8. So HHV8 causes Kaposi sarcoma, which looks like this, and EBV causes oral hairy leukoplakia, which presents in the mouth. Okay, so some people were getting confused and guttate psoriasis with P. rosea. So see, this is how P. rosea present. They are very, very small lesions. There is presence of Herald patch and here the lesions are present all along the lines of skin tension. I agree, pityriasis rosea is also present on the trunk and it is usually preceded by an upper respiratory tract or GI infection. But the important pointers here would be, you will have one large patch called as Herald patch, and then you will have lot of small patches and the lesions will be present around the skin tension lines called as Christmas tree pattern. The kind of scales that you see in pityriasis rosea are typically called as collarette of scales. Collarette of scales. Okay, so it is caused by human herpes virus. HHV6 and 7 are commonly implicated. Herald patch, Christmas tree pattern and collarette of scales are important findings. I hope my video and audio is all clear now. Very good. Okay, then what is this? I have a child who presents with asymptomatic plaque on the buttocks and this is the appearance. So what is the diagnosis? So this is a case of lupus vulgaris. Again, what are the important pointers? Here I have a plaque which is extending on one side and healing on the other side. The plaque is extending on one side and healing on other side, and you see areas of atrophy in between. This is classical lupus vulgaris. It is the most common form of cutaneous tuberculosis that you see in adults. In kids, the most common form of tuberculosis is scrofuloderma, where you would be given typically an image of the neck, and there will be lymph nodes from which there would be sinuses which will be coming out. Lupus vulgaris, you do a dioscopy, and when you do a dioscopy, you see this appearance because it is a granulomatous pathology. Okay. Sorry guys for the delay in the video. We are still working on it. I hope it gets better soon. But let's not stop the topic because we are already running late. So yes, you all are right. On dioscopy, you see apple jelly nodules. So apple jelly nodules are seen on dioscopy. Lupus vulgaris is the most common form of tuberculosis that you see in adults. Great, thank you so much. Now, when we talk about tuberculosis, another important thing that is asked in tuberculosis is about tuberculids. What are tuberculids? They are a hypersensitivity reaction to tubercular bacilli. So, there are different types of tuberculids. Commonly, you are asked about lichen scrofulosaurum and papillonecrotic tuberculid. Now, lichen scrofulosaurum you would usually see in children, and it will be present on trunk with follicular or perifollicular micropapillar lesions. PNT is seen in adults, it is seen in extremities, and patient presents with necrotic papules. Now, tuberculids are a hypersensitivity reaction. So, usually they can ask you about the criteria of tuberculids. So, remember, I will quickly tell them to you. Tuberculids are a hypersensitivity reaction. So, there is already a focus of TB somewhere else, from where the antigens or mycobacterial bacilli released in the skin, and the body mounts a hypersensitivity reaction. So, if you do Montus, it will be positive. So, Montus is positive, there is a focus of TB somewhere else. When you give ATT to the patient will improve. If you do a biopsy, you see epithelioid cell granulomas or tubercular granulomas. However, if you try to culture the bacilli from here, you would not be able to culture the bacilli because it is not an exact infection, it is a hypersensitivity reaction which is developing. But the treatment remains the same, you give ATT to the patient. Okay. So resuming our session on LLR dermatology, and we started with the genital ulcers. So genital ulcers is another very important topic which is asked in the exam, and there are 5 genital ulcers that we need to differentiate. So here I have put a table which will help us differentiate between the two. So if they are asking about syphilis, these are the important pointers. A single ulcer, a painless, indurated ulcer. Single, painless, indurated ulcer with non-tender shorty lymphadenopathy is typical of syphilis. The ulcer is called as a chancre and the causative organism is Treponema pallidum. Clear? However, if we are talking about, and we'll move on to chancroid first because this is called as soft chancre. This is called as soft chancre. This is multiple, painful, and is not indurated. So, it is a soft ulcer. It is not indurated but has undermined edges. So, chancroid and syphilis. Syphilis, single, painless, indurated. Chancroid, multiple, painful, non-indurated, but ulcers have undermined edges. Another important thing, incubation period. 9 to 90 days for syphilis and 2 to 5 for chancroid. Next, coming to donovanosis. Donovanosis is again a single painless ulcer like syphilis. However, here the base is not clean. The base is a beefy red granulomatous base with bleeds on touch. So bleeds on touch, beefy granulomatous base with single painless ulcer is donovenosis. Another important thing in donovenosis, there is no lymphadenopathy. However, you see pseudobuboes to be present, right? Pseudobuboes are what? They are donovenosis ulcers which are present at the site of lymph nodes. Then coming to LGV. LGV will not present with any ulcer usually. So even if it is present, the ulcer is very transient. So what it does it present with? It presents with lymphadenopathy. So here groove sign is present, elephantiasis is present, esthumine is present. Okay, I'll talk about each of them in little detail, but these are the important pointers. Then we should know the causative organism, Treponema pallidum for syphilis, Chlamydia trachomatis for LGV, Haemophilus ducreyi for chancroid, and Klebsiella granulomatis for donovenosis. All of these are very, very important points. Coming to treatment, in syphilis, you give benzathine penicillin, except neurosyphilis where you will use aqueous or crystalline penicillin. This is broadly, I am not talking in detail, but in general, benzathine penicillin 2.4 million unit. However, if it is neurosyphilis, you give aqueous or crystalline penicillin. LGV, you treat with doxycycline, chancroid with azithro, and donovenosis with also azithro. Okay, but the duration of therapy in donovenosis will be longer than in chancroid. Right? Now, quickly identify these ulcers. So, you have a single painless indurated ulcer with very, very clean base. We know this is syphilis. In syphilis, they are very, very fond of giving this also. This is the primary stage where I see chancre. This is the secondary stage where I see hyperpigmented macules on palms. So, if this image is given, they are mostly asking you about secondary syphilis, and this sign is called as Buschke-Ollendorff sign. We already discussed the treatment and causative organism. Sometimes they ask you an important investigation of choice. So, for syphilis, investigation of choice is dark ground microscopy, especially in the primary stage. Otherwise, we have various serological markers, but here we use dark ground microscopy in the stage of ulcer. Clear? Moving on to the next one. Before moving on to the next one, this is another important thing that they ask in syphilis. They give you this image and they ask you what it is. So, this is, don't confuse it with the condyloma acuminata or perianal wart. Look at the lesions. They are very moist. They are looking as if some papules have eroded. So, this is again a part of secondary stage of syphilis. And these are not mucosal lesions. These are papular syphilid which have eroded because of friction, and so they are seen as moist, very, very moist lesions, very soft lesions which are seen in the perianal area. These are very, very infective, and this is called as condyloma lata. Next, genital ulcer disease. I did not talk about this because this actually does not present as ulcers. It presents with coalescing vesicles and very, very superficial erosion. So, this is, we all know, this is herpes genitalis caused by HSV2 more than HSV1, and typically you have coalescing vesicles and superficial erosions. You hardly see ulcers. Very important, history of recurrence may be there. The primary episode is very, very painful. Secondary episode is less painful, less constitutional symptom. What test do? You do a Zang smear, and in Zang smear you see these multinucleate giant cells. Multinucleate giant cells are seen on Zang smear. Treatment is acyclovir. How much? 200 mg 5 times a day. Right? So, 200 mg 5 times a day is the treatment of choice. So, they will give you history of some sexual history, and then they will give you these different ulcers and ask you about it. What is this? Multiple ulcers which are soft, which have undermined edges. This is nothing but chancroid. It is painful, caused by H. ducreyi. And what is the investigation of choice? You do a gram stain. And what do you see here? In gram stain, you see school of fish appearance, as if the fish is walking in line. So, school of fish appearance or railroad track appearance. So school of fish or railroad track appearance is classical of chancroid. All the important points of the ulcer. What is this? We see a beefy granulomatous base. We know it is donovenosis. This is a pseudobubo. When donovenosis ulcer happens at the site of the lymph node, but there is no lymphadenopathy here. There is no lymphadenopathy here. And what do I see here? I see on GIMSA stain safety pin appearance. Safety pin appearance seen on GIMSA stain is the classical finding in donovenosis. So please remember all these genital ulcers and their important points. You should be able to differentiate. These are the points that you would need to differentiate them, and if you know these points, you will be able to answer your genital ulcer disease well. Okay, next, in this image, I have a 40-year male who's a chronic smoker, who's obese, who presents with these recurrent furuncles in the underarms area, in the groin area, and they heal with typically these kind of scars. So, in the question, they will give you something about metabolic syndrome, being obese, being diabetic, alcoholism, smoking, something would be given. Recurrent painful furuncles, abscesses or sinuses happening at the apocrine sites. Recurrent lesions happening at the apocrine sites and lesions typically healing with bridging scars. Then another important pointer that I gave you was chronic alcoholic or smoker or a diabetes patient. So when all this history is given, you know that we are dealing with hidradenitis suppurativa. Hidradenitis suppurativa is a disorder of which type of glands? It is a disorder of apocrine glands, where on the sides of apocrine glands, you have recurrent inflammatory papules, nodules, bridging sinuses, eventually healing with bridging sinuses. And very, very important thing, you also see polyporous comedones here. Polyporous comedones here, right? So these are other important pointers. You should be knowing about all of these points. This is classical of hidradenitis suppurativa, right? And recurrence is a rule. It is a chronic disorder, right? Next, sometimes they give you an image like this, or they tell you that there is a chronic non-healing ulcer on foot or legs of a patient, and you do all the investigations. You do microbacterial culture, you do bacterial culture, you do fungal culture, you do ANA, you do all the autoimmune profile. All your tests are negative. So this typically in history, they will give you all sorts of tests and they will say these tests are negative and patient has these non-healing ulcer which is painful on legs. So what is your diagnosis? So here my diagnosis is pyoderma gangrenosum. Pyoderma gangrenosum is a diagnosis of exclusion. So you first rule out infections, you rule out autoimmune etiology, you rule out mycobacterial infections. Nothing comes positive. Patient has non-healing painful ulcer with heals with typical cribriform scarring. Lesions heal with cribriform scarring. You know your diagnosis is pyoderma gangrenosum. What class of disease is pyoderma gangrenosum? It is a type of neutrophilic dermatosis. It is a type of neutrophilic dermatosis, right? So some ulcer, and sometimes they can also give you heals with cribriform scarring. So please remember this, right? Now, next. Another important question that you get in your exam is you get a female or a male who is presenting with painful nodules on the face. So typically pointing towards history of acne. So in acne, two kinds of images may be given to you. One which is depicting comedones. Comedones you all know are nothing but dilated pilosebaceous duct. They can be open comedones or closed comedones. And second important question is comedones are a characteristic feature or are a specific skin lesion seen in acne. and then they can ask you the treatment of acne based on the stage that they have given. The most common staging which is given is this grade 4 acne, where you see multiple nodules or cysts. So, a nodular cystic acne, and they ask you what would be your treatment of choice. So, treatment of choice for nodulocystic acne, we all know, is oral retinoids. Oral retinoids, which one? Oral retinoids, they can also give you isotretinoin or acetretin. Please don't mark acetretin. Acetretin is an oral retinoid used in psoriasis. Isotretinoin is the oral retinoid that I use in acne, right? Then related to isotretinoin, you can be asked whether they can give you a female in childbearing age group. Can a female in childbearing age group be given isotretinoin or oral retinoids? Patient can be given isotretinoin. Sometimes what happens, students say childbearing age and they say they cannot be given. Isotretinoin can be given in childbearing age group, but you have to have 2 negative UPTs before prescribing, and you have to counsel the patient about contraception. After stopping isotretinoin, patient may conceive. Some people say 1 month, some people say 3 months after stopping isotretinoin. So, a woman in childbearing age group, if presenting with nodulocystic acne, can be given oral isotretinoin with due precautions. Okay. So, most common side effect of isotretinoin is teratogenicity. Not most common, but most dangerous. I'm sorry. So, teratogenicity is its most dangerous side effect, and that is why in childbearing age group, you're careful while prescribing it. But you should know other side effects also, like dryness, cheilitis, superadded infections. All this can happen. Even flare of acne can happen, and it can also cause some severe skeletal abnormalities like dish. Okay. So, isotretinoin and nodulocystic acne is something which is asked. You should know the isotretinoin side effects and whether it can be given in childbearing age group or not. Right? Okay, some of you wanted me to discuss neurocutaneous syndromes. So, I've put some questions on neurocutaneous syndromes. So, in neurocutaneous syndromes, 2 syndromes are very important for you. What is this? We all know we are seeing neurofibroma. So, this is a case of neurofibromatosis 1. Neurofibromatosis 1 or NF1, right? It is an autosomal dominant disorder. We all know that. Okay, what are the features that you see? You see neurofibromas. You can see neurofibromas, or you can even see plexiform neurofibromas. Okay, then what is this? This is cafe au lait macules or CAMs. CAMs are also seen in neurofibromatosis. Then they can point out this. What is this? This is leash nodules. So, in neurocutaneous syndrome, either they will give you the image and ask you what it is, ask about its specific feature, its chromosome, or inheritance. Now, sometimes they may also give you history which is suggestive of a neurocutaneous syndrome. So, they will give you mental retardation or seizures which may be present. How do I remember what are the features of NF1? So, you can remember it with the help of a mnemonic, cafes. C for cafe au lait spots, which should be more than 6. Size should be more than 5 mm and more than 15 mm in prepubertal and postpubertal individuals. A for axillary or inguinal freckling. Axillary freckling is also called as crow's sign. F for fibromas, neurofibromas, which may be 2 or more, and plexiform neurofibroma. If even one is present, it fits the criteria. Then leash nodules, which are nothing but eye hematomas. So, E for eye hematomas. S for skeletal abnormalities like sphenoid wing dysplasias and leg bowing. Then there can be a first degree relative which may have NF1. So, first degree relative or family history positive. Then patient can have mental retardation and history of other neurological disturbances. So, in neurofibromatosis, remember CAFES, CAFES, and that will help you. right? Okay. Then the other neurocutaneous syndrome that comes up is you're given an image like this and you are said that to identify these, or you're told to us to know the diagnosis. So when you see these red color papules which are localized on the nose, on the cheeks, these are nothing but cutaneous angiofibromas which are seen in tuberous sclerosis. Don't confuse it with acne or sebaceous gland hyperplasias. These are cutaneous angiofibromas, or also called as adenoma sebaceum. Adenoma sebaceum or cutaneous angiofibromas. They are a feature of tuberous sclerosis, also called as epiloia. Epi means epilepsy, LO means low intelligence, and A means adenoma sebaceum. Okay, so when you see these, don't confuse. Acne is not such monomorphic. Acne will not present with just these red areas only localized here. These lesions increase during puberty. Now, when we have tuberous sclerosis, you should quickly also know about other features that are important for tuberous sclerosis. What is this? This is ash leaf macule. This is a leaf-shaped hypopigmented lesion that is usually seen on trunk, or you can see something like this, a leathery patch on the trunk called as shagreen patch or collagenoma. Shagreen patch or collagenoma. What is this? These are periungual fibromas or Keenan's tumor These are some important features. However, again with tuberous sclerosis, you can remember the mnemonic hematomas. Tuberous sclerosis is full of hematomas. So you can see hematomas in liver, lung, kidneys, everywhere. Then A for adenoma sebaceum, M for mental retardation, A for ash leaf spots, rhabdomyomas in kidney, T for tubers in the brain, optic hematomas, mitral regurgitation, astrocytomas and seizures. You do not need to remember everything. If you just remember hematomas, you would know that, okay, what are the different features. So in tuberous sclerosis, mental retardation, seizures, astrocytomas, all of these are very, very important features. Usually they give you image of adenoma sebaceum and ask you what it is, or they give you image of Keenan's tumor or periungual fibromas, right? So this is very, very briefly about neurocutaneous syndrome. So, okay, next important question that you get is, a parent gets a child who has history of continuous itching. So, there is typical parental history of itching by the child, and any of these manifestations may be present. A child may present with facial dermatosis or lesions on the extensors, or if it is a child. So, if it is, infant, you would see face involvement and extensors involvement. If it is a child, you would typically see flexure involvement, and if it is an adult, you would see hand involvement. This associated with itching. Itching is a constant feature. You know you are dealing with atopic dermatitis. Atopic dermatitis is a type of endogenous eczema. It is usually an IgE mediated disorder. So, IgE is one test which is positive. However, atopic dermatitis is always a clinical diagnosis. It is a clinical diagnosis. You do not have any particular lab test which will help you. IgE may be positive, but it is typically a clinical diagnosis, and there is a diagnostic criteria which is being given by Hanifin and Rajka. Hanifin and Rajka gave the diagnostic criteria, and this name is also important. The child will typically present with recurrent facial dermatitis. An infant will present with extensor involvement and face, child with flexures, and adult with hand dermatitis. So they ask you the diagnosis, then they can ask you about the pathogenesis. There is high IgE, there is reduction in filaggrin, there is increased transepidermal water loss. Here there is barrier abnormality, and also the patient may have other history of atopy in the form of hay fever, in the form of asthma. Then there may be a positive family history. So all these are very, very important pointers. The next important pointer is they can give you an image like this, can ask you what it is. So atopics have an extra fold of skin below their lower eyelid, which is called as Denny-Morgan fold. So Denny-Morgan fold is an extra fold of skin on the lower eyelid seen in atopic patients. They give you this image, they ask you the diagnosis, or they ask you what it is, right? How do you treat these patients? You moisturize, most important. You identify if there are any allergens increasing the allergy, you withdraw that, and you can give topical steroids, you can give oral steroids, you can give cyclosporin, and there is a newer biological which is available, which is called as dupilumab. The new biological which is available for atopic dermatitis is called as dupilumab, right? Okay, then sometimes they will give you this. A child presents with asymptomatic, ill-defined, hypopigmented, scaly macules and patches on the face. Now here there are 3 DDs that you need to differentiate from, okay? What is this? So when you see these hypopigmented patches, not 3 DDs, so one, you should know whether it is indeterminate Hansen or pityriasis alba. How do you differentiate between this? So this particular image is of pityriasis alba, which is a type of, again, an endogenous eczema. Now, typically, what are the pointers here? One, there are multiple lesions. Lesion may be hypopigmented, they are ill-defined. That can happen with other DDs also. But they are mildly scaly, they are multiple and mildly scaly. And there may be history of atopy. So these 3 are important pointers: multiple lesions, mildly scaly, and atopic. However, if they want to ask you about indeterminate Hansen, one, they may give you an endemic area. They will tell you the lesion is solitary. Indeterminate Hansen will not have multiple lesions. It will not be scaly. And it will not be episodic. What do I mean by that? P. alba can recur. It is more commonly seen in winters. So it can recur, but indeterminate Hansen does not recur. It is not episodic. Clear? Then sometimes you may confuse with pityriasis versicolor. Versicolor usually happens on the trunk. It can happen on face, but trunk is the more common site. Brany scales will be present, and there may or may not be mild itching, and there you do KOH. How do you treat pityriasis alba? You just give emollients and mild steroids. So again, when they give you this image, please understand the difference between these 3 DDs. Pityriasis is scaly, alba is white, right? And it is not vitiligo. Vitiligo is depigmented. This is hypopigmented. Okay, so don't even confuse with vitiligo here. Moving on, another important question that you get is a child or an adult presents with some history of proximal myopathy may be given in the form of unable to raise your hands, unable to climb the stairs. So there will be history of proximal myopathy, and then they can give you these images and ask you the diagnosis, or they can ask you what is this characteristic lesion seen. So when you have proximal myopathy with these red lesions which are present in the distal, in the interphalangeal joint or on the metacarpophalangeal joint, you know we are dealing with dermatomyositis. Dermatomyositis is a connective tissue disorder where we see involvement of skin and muscles. And which class of muscles? Typically, proximal group of muscles are involved, right? In skin, the characteristic or pathognomic features is presence of these lesions which are called as Gottron's papules or Gottron's sign. What is the difference? Gottron's sign is just plain erythema, whereas papules are raised lesions. They're present at the same site, but got transine and got papules. Now, sometimes this arrhythma which is present is typically confluent macular violaceous arrhythma. So, it is flat, it is violaceous arrhythma. When you see it around the eyelids, it is called as heliotrope rash. So, if you get an image like this, heliotrope rash or CMV or this arrhythma which is present around the eyelids is also a feature of dermatomyositis. But it is a characteristic feature. Gottron's papule and Gottron's sign are pathognomic feature. So, these are my pathognomic features. Sometimes they give you the question, the pathognomic feature of this condition is, and they may give heliotrope rash, and since you have heard about heliotrope rash, you mark that. Please don't do that. Heliotrope rash is characteristic, but the most important sign is papule, Gottron's papules and Gottron's sign, and there may be history of proximal myopathy. If they ask you how do you investigate, you look for muscle enzymes, you do a muscle biopsy, you do a electromyograph. Okay? Treatment is steroids. For skin, you use hydroxychloroquine sulfate and also you use methotrexate. Clear? But they hardly ask you the treatment. They are more interested in you diagnosing this condition. Okay. What do you see here? You see lot of periorificial lentigenes. That is what you're seeing. Whenever you see this image, the question can be what is the diagnosis? So, any condition you see periorificial lentigenes, the diagnosis is Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is a GI polyposis syndrome. So, apart from periorificial lentigenes, which is like the clear-cut sign, you have GI polyps here. Then, in the history, they can give you family history of similar condition, or they can say the father died of polyposis or stomach cancer or something like that. So, what will you do? You will do regular endoscopy. So, if you see any patient with this periorificial lentigenosis, they can ask you the diagnosis, they can ask you what thing it can be associated with, or they can ask you how will you monitor these patients. You will look for look for GI polyps by doing regular endoscopy. So, this diagnosis is important. Okay. So, next you have a patient who presents with recurrent vesicular eruptions. Recurrent vesicular eruptions on axilla. And you are given an image like this where you see few vesicles, ruptured vesicles, scaly vesicles, small erosions which are present on the underarms. So, when you see this term recurrent vesicular eruptions on underarms, or they can also say patient applied multiple steroids or antifungal creams, but the lesions keep recurring, please think of Hailey disease. Hailey disease. Now, quickly, because we are short in time, I am going to discuss both these two conditions, which are both genodermatosis. They are caused by defect in calcium transport, and they are both asked in the exam. So, Darier's disease and Hailey disease both are autosomal dominant. Both are caused by defect in calcium ATPase, but they ask you the specific gene which is defective. So, specific gene which is defective here is A2P2A2 gene. Here it is 2C1. So, just remember C is not there with D. Okay. So, C is not there with D. So, Hailey has 2C1 and Darier's has 2A2. Now, the clinical features which are different here are in Darier's disease, seborrheic areas are typically affected, whereas in Hailey you have intertriginous skin which is affected. Clinically, both these conditions are absolutely different, but their defect is same. So, clinically in Darier's disease, you will have seborrheic distribution and you will see warty verrucous-like lesions which are greasy, which gives you a sandpaper feel. Whereas in Hailey, you have recurrent facet vesicular lesions, right? Now, histology is again something which is asked, especially for Hailey. So when you do a histopathology for Hailey-Hailey, you see acantholysis, just like in pemphigus. But here, there is dyskeratosis also, which is present. So dyskeratosis is a feature which is seen in both Darier's and Hailey-Hailey. Okay, that is why they are also called as, so in histopath, sometimes they ask you dyskeratosis is seen in. So benign dyskeratosis is seen in Darier's and Hailey-Hailey. Then dilapidated brick wall appearance. So dilapidated brick wall appearance is typical of Hailey-Hailey disease. Okay. So next, you can be given this, a child who has been born in a taut, shiny film all around, or you can be given an image like this where you see scaly, fissured lesions all over the body. So you know you're dealing with ichthyosis. And what kind of ichthyosis? If you see this image, this is an image of collodion baby. Collodion baby is seen in lamellar ichthyosis. So we know that there are 3 types of ichthyosis that are asked. Usually ichthyosis vulgaris, where you have scaling which is present on the extensors, they are fine scales. X-linked recessive ichthyosis, which is seen in preauricular areas on the neck, on the flexures, and you have dirty looking scales. Then lamellar ichthyosis, which typically presents with colloidal membrane, or a baby is born in a chili or a shiny parchment-like membrane, and it also has erythroderma. The ichthyosis is present all over the body. Sometimes later in life, lamellar ichthyosis may just be left with fish-like scales on the legs. So can you see this? Fish-like adherent scales on legs. Lamellar ichthyosis is caused because of defect in transglutaminase. X-linked recessive ichthyosis is caused by SDS gene defect. Ichthyosis vulgaris is caused by filaggrin defect. This is caused by transglutaminase defect, right? So usually, in history in ichthyosis, they will give you something. For ichthyosis vulgaris, they will give you an atopic child presenting with palmoplantar hyperlinearity, and then ichthyosis happening on the extensors. For X-linked recessive ichthyosis, they will tell you about inheritance, which is X-linked recessive, then the onset, which is present after 3 months. Lamellar ichthyosis is the only ichthyosis which presents at birth. Both other ichthyosis will present usually after 3 months of age. So if you know these important features, you will be able to differentiate between various kinds of ichthyosis. This is very, very simple. I will quickly walk through it. You all know this, but they give you this question. Multiple family members presenting with itchy lesions, which are with especially nocturnal itching, other family members being affected, the classical sites being affected. You all know we are talking about scabies. The questions that are asked is, what is burrow? Burrow is the special lesion which is seen in scabies. What is a burrow? It is a tract which is laid down by the female mite where it lays eggs. Where is burrow present? It is present in the stratum corneum. However, it can extend up to stratum malpighi. Then, what are the classical sites affected? The classical sites affected are depicted by a circle which is called a circle of Hibra, which involves the web spaces, then the elbows, the neck, typically below neck infestation in adults, and in infants you can also see involvement of face. So burrow, circle of Hibra, it is caused typically by the female mite. Another important question that they ask you in scabies in symptoms, nocturnal itching is important. Then another important question that they ask you is about treatment. So what is my treatment of choice? I give 5% permethrin. 5% permethrin is the treatment of choice, but very importantly, the treatment need to be repeated weekly. All family members needs to be treated, and beddings and linens should also be treated. So treatment of all family members and linens and beddings also needs to be treated, right? So this is very, very important. They ask you this. Then they have once asked you, what is it? It is a type of water washed disease. A disease if you take bath, if you keep your hygiene well, the disease can be washed off with water. This is how you can remember it. It is usually seen in overcrowded places, right? So you know what is it caused by? It is caused by a mite called as Sarcoptes scabi. Sarcoptes scabi is the mite which is causing this. Then they ask you something about the variants of scabies. So you should know crusted scabies or Norwegian scabies, which is the most severe form of scabies seen in leopards, seen in patients with Down syndromes or neurological syndromes. Okay. Then animal scabies, where you see no burrows, or nodular scabies, which you see in axilla or genital area, which is nothing but persistent hypersensitivity reaction to the mite. Right? Okay. Then they are fond of this and they give you this question almost always. A farmer or a chronic alcoholic presents to you with these manifestations. So what do you see here? You see a kind of photoallergic rash which is present on the neck, on the dorsa of hands. And a lot of times you would say it is a photoallergic dermatitis, but it is not. Look at the lesions. Here you see a typically a necklace appearance. This is a classical case of pellagra, which is caused by deficiency of niacin. And in pellagra, what do they ask you? They ask you about 3Ds. So they can ask you what other features may be associated with it. So dermatitis, diarrhea and dementia. And then sometimes they give you hints like a chronic maize eater, a chronic alcoholic can present with this. So you should know what it is caused by. It is caused by deficiency of niacin and 3Ds, and you should be able to identify this image because this is what it is usually given. Right? Another important question, they can give you this image, they can ask you the association. So what do you see here? You see hyperpigmented, velvety skin texture which is present on neck or underarms. Then what else they can give you? They can say the patient is asymptomatic, patient is obese, patient may be diabetic. All of these features may be given. So you should be able to identify that this is Acanthosis nigricans. Acanthosis nigricans is seen in patients who are diabetic, who are obese, who are insulin resistant, and typically presents with hyperpigmented velvety skin. Now they mark this and ask you what is it. So skin tags are associated with Acanthosis nigricans. So what you can see on top of Acanthosis nigricans here is skin tags. Then they ask you about association. So Acanthosis nigricans can be benign. However, it can also be malignant, and so it is put under paraneoplastic dermatosis. Now remember, there was once a question, is Acanthosis nigricans associated with cutaneous malignancies? No, it is not. It is associated with malignancies but not cutaneous malignancies. It is associated with GI cancers and lung cancers. Also, malignant AN is different from benign AN. Malignant AN is more widespread. It will be present all over the body. There may be associated tripalms or Acanthosis nigricans on the palms, which may also be seen. It is sudden in onset and it is very, very rapidly progressive. Okay, so Acanthosis nigricans is another important topic that is asked. Then this is another common image, a 60-year-old male present with an ulcer which is present around the eye. So usually they will give you on the nose or around the eye, somewhere on the medial canthus, and you would typically see that this ulcer has an overhanging margin, has some telangiectasia, some redness. So you have to identify what this is. So mostly they ask you about identification of this. So this is basal cell carcinoma, one of the most common cutaneous malignancies, which presents with this rodent ulcer, as they call it. An ulcer with overhanging margins, with bleeding, with telangiectasias, with an erythematous base. It has good prognosis, it does not metastasize much, and vismodegib is been once asked. It is a hedgehog pathway inhibitor, and this is used in treatment of basal cell carcinoma. So vismodegib is a hedgehog pathway inhibitor used in treatment of basal cell carcinoma. Mostly they tell you to identify this lesion. I wanted to talk about this. Sometimes they give you this histopath image where they are depicting a collection of neutrophils, which is microabscesses, and they want to ask you what this microabscesses is. Now, when they ask you in the question, they will give you something like this: a history of presence of erythematous lesions on the limb girdles which are not improving, or erythematous scaly lesions which is progressing to form plaques and nodules, typically affecting the girdle. Then they give you this histopath image and they ask you what it is. So this is nothing but Potter's microabscesses. These are Potter's microabscesses, and you see it in mycosis fungoides, which is a type of cutaneous T-cell lymphoma. Typically presents on the limb girdle. It can start with macules and go on to form papules, plaques, and nodules. So mycosis fungoides has Potter's microabscesses. Monro's microabscesses were present in psoriasis. M is not present with them. Here we have Potter's microabscesses, right? Another common image that is given to you, there is a hyperpigmented lesion which is very, very hairy and usually present in an adolescent individual. It is not present from birth. It is present in adolescent or adult individual, and typically you would see hypertrichosis over lesion. So you have to identify the lesion. This is nothing but Becker's nevus. It is a type of epidermal nevi which presents with hypertrichosis and is present and begins to form in adolescent or adult age group, giving us a hint that probably there is some androgen involvement here. Right? Okay. So I think those were some of the important topics. Now I have put in some important questions from last year, from previous year INI-CET exam, which I thought I could not discuss in the topic. So we'll quickly go through them. Which of the following will not commonly present as shown in the image below? So in the image, they are giving you an annular scaly lesion. You would be able to identify that this is an image of tinea or dermatophytic infection. And you all know that a dermatophytic infection is either caused by trichophyton, epidermophyton, or microsporum. And aspergillus can never cause a tinea or dermatophytic infection. So which is not commonly will not present as this? Aspergillus. A male baby born to a non-consanguineous couple develops blisters on areas of friction. So a male baby born on a develops blisters on areas of friction. Their previous child also had similar complaints and died at the age of 2 weeks. What is the diagnosis? Now, whenever you see blisters at the site of friction, you are dealing with a mechanobullous disorder. Which out of these is a mechanobullous disorder? It is epidermolysis bullosa. Epidermolysis bullosa presents on areas of friction. It is a genodermatosis, so you will have a positive family history, right? CBDC will not present with family history. There will be not blisters on areas of friction. It is present on trunk. Congenital syphilis, we all know. Neonatal pemphigus will again present with blisters on the trunk. There will be no family history and no blisters on areas of friction. So these two important things help me differentiate epidermolysis bullosa from rest of the conditions. A patient was treated with steroids for psoriasis. On stopping the treatment, he develops fever, malaise, and lesions as seen in the image below. What is the most popular probable diagnosis? Now remember, a psoriasis can become unstable psoriasis when The patient is either given steroids or tar. These are the common things that they give you in exam. Now, when a psoriasis becomes unstable, it will usually present with pustular lesions. Now, remember, in psoriasis, in histopath, we discussed microabscesses. So, there are microscopic pustules, but now the pustules have become visible. So, when you have these pustular lesions, when you have these lakes of pus, it is nothing but an unstable psoriasis triggered by steroids or sometimes triggered by tar application. And so the answer would be pustular psoriasis. Don't confuse it with secondary infection or drug-induced reaction or subcorneal pustulosis. So a patient of steroid psoriasis, anytime given steroids or tar, they are going to ask you about pustular psoriasis. Another form of unstable psoriasis is erythrodermic psoriasis, where you see erythema and scaling, which involves more than 90% of body surface area. Okay? So, but here the answer would be pustular psoriasis. Here you see lakes of pus forming. The treatment of choice I already discussed in such cases is acetretin. Then, a 30-year-old patient presents to the clinic with hypopigmented patches on the skin. On examination, there are a few slightly raised lesions with loss of sensation. So, you know we are talking about leprosy, there is loss of sensation. Skin smears reveal no AFPs, which is the most likely diagnosis. Obviously, it's not these two. Now, since you're not seeing acid-fast bacilli on smear, you know this is paucibacillary leprosy. In paucibacillary leprosy, you do not see AFBs. Multibacillary leprosy will present with AFBs. Also, here the patches are few. Right? Which among the following is correct regarding the healing of leprosy if left untreated? So, if leprosy is left untreated and the disease is allowed to follow its natural course, which is correct? First option, no spontaneous remission is seen. No, that's not correct. In fact, if a patient is infected by a lepra bacilli, 90% remit on their own. We do not even get the infection. So, spontaneous remission is seen. Half of the cases resolve spontaneously after bacillary exposure. No, it is much higher. 80 to 90% of the cases can resolve after bacillary exposure. Spontaneous remission is more common in children than in adults. Now, this is little tricky for you, but I just wanted to explain here. There is no data to say so. But let's look at the last option. Indeterminate leprosy will have more remission than tuberculosis. Now, if you look at these options, you know obviously this is true because we have studied that indeterminate leprosy is one which most of the times will heal on its own. So, remission would definitely be more in indeterminate leprosy than in tuberculoid leprosy. Now, only confusing option is this because generally children are believed to have better immune system, but to tell you there is no proven data yet. So, here we will go with option 4. Since it was a little controversial question, I thought I'll put it here. A child presented with asymptomatic lesions on the forearm and on the shaft of the penis. The lesions on the forearm are shown below, which is the most likely diagnosis. Now, here you see lot of shiny papules which are asymptomatic and present on elbow and shaft of the penis. This is a condition which is called as lichen nitidus. Lichen nitidus is present typically with these features, and on histopath you see ball in claw appearance. So, when you do a histopath, you see an infiltrate which is like a ball which is held in the claw. So, ball in claw appearance on histopath and these shiny asymptomatic papules on forearms and shaft is a typical feature of lichen nitidus. You all know the other options and we know that's not the case. Okay. Slap cheek appearance is associated with which of the following? Now, look at the options. You've never read about this. So, slap cheek appearance, we all know, is seen with parvovirus. So, sometimes they want to test your extended knowledge about a virus. Now, usually we have studied slap cheek appearance, parvovirus and everything. But here they want to ask you that what are the associations with parvovirus B19? Now, pure red cell aplasia is associated with parvovirus B19. Now, these are some of the important major diseases or associations of parvovirus B19. Since they may ask you anything, so I've put on the table. So we know that slap cheek appearance is seen with fifth disease or erythema infectiosum. That's one thing that we all know. But parvovirus B19 can also cause arthropathy. It can cause aplastic crisis. It can cause persistent anemia. It can also cause hydrops fetalis and congenital anemia. So all these diseases are also associated with parvovirus B19. Match the following Woods lamp finding. Woods lamp, we all should know what is Woods lamp. It is a low output mercury arc lamp which is covered by wood filter. You should know the composition of wood filter, that it is formed of barium silicate and 9% nickel oxide. You should know the wavelength and its peak. Then you should know important features. So erythrasma, we all know coral red fluorescence. Pityriasis versicolor, we know yellow fluorescence. Tinea capitis and vitiligo. So vitiligo is milky white. Tinea capitis is greenish fluorescence. So you should know these fluorescence which are seen with pityriasis versicolor, tinea capitis, P versicolor, erythrasma, vitiligo. What happens to melasma? The epidermal pigmentation gets accentuated or increased. Dermal pigmentation appears bluish or shows a Tyndall effect with this. Okay, then they can give you porphyria where you see red urine. Next question, a female patient presents with active genital warts with a history of recurrence, but her husband does not have it. What advice will you give to prevent transmission? For genital warts which is caused by HPV, give continuous prophylaxis to the patient. No, this is not done for any STD. Give prophylactic antivirals to the husband. Again, does not work. We know there is no antiviral for HPV. Give antivirals whenever active lesions are present. Again, not valid. Do not involve in intercourse when active lesions are present. This is correct. Or use barrier protection. Any of these answers would be correct. Use barrier protection or do not involve in intercourse when you have active lesions. Clear? So that's it from my side. I have tried to cover all the, I would not say all, but most of the important topics. And what I gathered is that you guys are very well prepared. Just keep up the confidence. Just keep revising your subjects well and you would fly high and you would have an amazing exam. So all the best and do enroll for your for the champions exam. Give the test, gain more confidence, study more, sleep well. All the best and we're always there to help you out. Thank you so much.